Welcome, everyone. Gather your breakfast, get settled. So welcome. Welcome to the Society for Liaison Psychiatry Spring Symposium. We're very excited to bring this event to you today with our sponsorship from PRMS. My name is Anna Dickerman. I'm the chief of the CL service at Cornell, and I'm also the secretary of the SLP. I will be emceeing today's event in place of our beloved president, Dr. Qureshi, who's not able to attend today. She's sick. So we have three great speakers lined up for you today. The main theme of today's session is going to be non-traditional roles for CL psychiatrists. And our first speaker is Dr. Ji-hoon Jeff Ha, one of my colleagues who I'm very happy to present today. And he's going to be talking about CL psychiatrist functioning as an intensivist. So Dr. Ji-hoon Ha attended UCLA, where he earned his Bachelor of Science in Biochemistry. He then attended St. George's University School of Medicine, where he earned his medical degree and graduated magna cum laude. Dr. Ha completed his internship and adult psychiatry residency training at SUNY Downstate College of Medicine, where he served as chief resident. During his residency training, he also completed training in psychodynamic psychotherapy at the Psychoanalytic Association of New York, affiliated with NYU School of Medicine. After completing residency in New York, he went on to finish his fellowship training at Stanford University School of Medicine to specialize in consultation liaison psychiatry. Dr. Ha is currently working as an inpatient consultation liaison attending at NYP Weill Cornell campus. He has special interest in critical care psychiatry and neurostimulation. So very excited to welcome Dr. Ha. And I also wanted to mention we are going to be raffling off some great prizes that you see here at the front of the auditorium or the conference room between each talk. So please buy some tickets. These events are not free to put on, and we certainly need all the support we can get. So thank you guys, and Dr. Ha.
Can you guys hear me? Okay, cool. Hello, well, thank you for the kind introduction, Dr. Dickerman. We'll just quickly start. I'll be talking about CL psychiatry in critical care setting. I have nothing to disclose. I'll just quickly talk about myself again. I'm an assistant professor of clinical psychiatry here at Weill Cornell Medical School. I'm currently working as an embedded inpatient CL psychiatrist for our hospital service at NYP Weill Cornell campus. And I'll be, before I get into my topic, I actually want to talk about how I got interested in critical care psychiatry. I finished my residency here in New York City in 2020, and I went out to fellowship in California. I was thinking that I was going to enjoy the nice weather, be outside, but the world had different plans for everybody at the time. So COVID hit, and our training was actually, we had to do about 6 months in ICU and 6 months in general. So as a fellow, we do 6 months. We lead a team in 6 months in ICU settings and 6 months in general settings. But in the beginning, there was a lot of COVID cases that were coming in to our hospital, and of course, it was like that for everywhere. But all the ICUs were turned into mostly medical ICUs, and a lot of patients were intubated, on vents. And one of the first consult that I got when I started my fellowship was, I get a page, I call back, and they said, "Hey, it's patient so and so with no past psych history. Came in with COVID pneumonia. We're lowering propofol. The patient is getting agitated. Help us out." And I said, "I think you got the wrong consult. Please call us back." But lo and behold, there was like the majority of the consult that we were seeing, and I learned a lot during my fellowship training. And there were some cases where we were able to help out. Even during COVID pandemic, that they couldn't get off events because they were so agitated. But we were able to work with some of the medications that we have to reduce the delirium as much as possible. And so they were able to participate in PT for them to even qualify for a lung transplant. And they were able to get the lung transplant, and they were able to survive the whole ordeal. And it really felt great. And I felt like we could make a really big difference in critical care setting. So that's how I get interested in, critical care psychiatry. There are just a couple of things that I want us to get. There's two main things that I want us to get out of this talk. The first is just know that we have a place in critical care unit. Psychiatrists can definitely be there and help out. And second is to learn the basic lingos, at least the language that the critical care doctors use when we're talking about delirium management and agitation. Is because if we know the language, and we speak their language, and they're going to listen to us better. So if you want to practice critical care psychiatry, we should try to learn their at least some basic language of what they're speaking. Okay, is it? Oh, okay. So before we get into actually talking about critical care psychiatrists, I want to talk about what the role of a psychiatrist is. According to APA, a psychiatrist is a medical doctor who specializes in mental health, including substance use disorder, and psychiatrists are qualified to assess both mental and physical aspects of physiological problems. And I highlighted the physiological problem. And our parent organization, SLP, according to them, CL psychiatrists provide expert psychiatric care for patients with complex medical conditions to all inpatient and outpatient primary care and specialty services. And we know the complex medical condition is important because each and every medical problem bring on a lot of different nuances and difficulties that the patient have to overcome. That's why we have such so many different subspecialties within our field, such as psycho-oncology, HIV psychiatry, and transplant psychiatry, you name it, right? So I think that ICU psychiatry can actually fit in there as well, because critical care is when the patients, I believe, is at the most vulnerable state, and is when they're most complex and their psychiatric illness. Oh, I don't say psychiatric illness, but their psychological stress is at a heightened state. And if you can see, I got this from Ted Stern's paper, where consultation physicians and psychiatrists can actually be doing can wear a lot of different hats. So what is the role of CL psychiatrists in critical care setting? So why critical care? And I was talking about it. Have you guys ever been to critical care unit and just sit there for a while? If you haven't, I recommend you try. The first thing you'll hear is the nurse tapping on your shoulder and like, get out of my seat. That's how you're gonna be. But if that doesn't happen, if you sit there for about 5 to 10 minutes, you'll hear beeps all around. Some folks are running around, and there might be code next door. I mean, it's not a pleasant place to be. And as you're sitting out there without any lines or anything like that, but as a patient who is laying in bed, just like this, you go in, you get this monitor here beeping here, you get all this drips beeping, you get this vents making noise, and you get probably there's like hemodialysis, you get all this, and you see all this lines. It's very, very uncomfortable setting for these patients. And as I said, I think they're at one of the most vulnerable states in their entire life. And you just don't buy yourself into ICU. You can't just pay for it. You got to be really, really sick to get into ICU, right? So the reason why we should care about critical care is because I think the patients are at the most vulnerable states, both physically and psychologically. And another thing is I keep saying the vulnerable because they are really vulnerable. You're literally laying there and someone's watching you the whole time because they have to be careful. If something happens, they got to go there. So I think we have critical care setting is very important for us as a psychiatrist. So I want to talk about what we can actually help within critical care, critical care setting. So in inpatient setting, of course, there are a lot of things that we usually can help, such as, patient a post-serious suicide attempt, patients with, malignant catatonia, severe serotonin syndromes, NMS, patient with severe eating disorder requiring, ICU care, and so forth, and severe alcohol, which are all those things combined together. But one of the bread and butter consults or the treatment that we're going to be helping out is delirium management in inpatient, and I'll be talking about that bulk of it in next few slides in terms of how to manage it and how to approach it. Another thing that we have to think about in critical care setting is an outpatient critical care setting. It's not an actual intensive care unit, but a lot of patients who actually go into ICU, when they come out, they suffer from what we call PICS, is post-ICU care syndrome. And I'll touch upon it a little bit later on at the end of the talk. But it basically means there's three things that patients suffer from. First, mental health. A lot of patients suffer from depression, anxiety, PTSD. Second is their cognitive delay, or cognitive decline. The third is physical limitations because the patients are in their bed for a long time. There are a lot more studies that are being done these days from actually critical care doctors too, where they're setting up an outpatient clinic and to continue to follow patients to help for them to be adjusted back into their normal life after such a traumatic experience in ICU. So having said that, we talk about why and what, and let's talk about how we can actually contribute as a CL psychiatrist. So I think we have unique skill sets as a CL psychiatrist. First, I think because we have to give medications in medically complex patients, we are very, very expert. I think we are experts in psychopharmacology, so we need to know our mechanism of actions for our drugs really well, drug-to-drug interactions, different side effects, half-life, and you name it, cytochrome P450 interactions and everything. Another thing is that I think we recognize our patients' distress a lot more. What I'm trying to say is, I think a lot of what happens is when we're in this setting, especially in a critical care setting, is you get to see the numbers because you don't really get to talk with the patient that much. The doctors don't really get to talk with the patient that much, so you really see the numbers. But I think as a psychiatrist, when we go there, we try to really understand who the person is, the family members there. We really try to understand where this person is coming from. Maybe understand their cultural background to incorporate that into care, and that kind of looking at it like a holistic approach to providing care for patients who are in ICU, and that I think is very, very important. And lastly, there is a liaison role for sure that we usually do in regular inpatient setting or even an outpatient setting. But I think it's really critical in critical care because it prevents different silos of nurses, pharmacists, PT, OT, nursing staff, and they have millions of consult team that comes in to try to help out because there are multi-organ failures for these patients. So the liaison role to make sure that everybody is bonded together to provide the best care for these patients is also very important. Now, having said that, using all those skill sets together, I think we want to try to, the ultimate goal is trying to reduce the morbidity and mortality within the ICU setting. And, the next thing I'm going to present is one of the the words that the critical care doctors use a lot. It's called A to F bundle. What it is actually it was created by Dr. Wes Eli. He's a critical care doctor at Vanderbilt University. And what this basically is acronyms of different words combined together. So A stands for assessing and managing pain, and B stands for both spontaneous awakening trial and and spontaneous breathing trial. It means that you want to try to awake the patient as much as possible, make them a little bit less sedated, and also is trying to have them breathe on their own rather than relying on ventilator as much as possible. C is the choice of analgesia as well as sedative drips, which analgesias and sedative drips would be the best. And D is delirium management, assessment, and prevention. And we can help a lot from that perspective. E, early mobilization and exercise. So we get PT right away as soon as the patient comes into ICU. As soon as the patient is safe to do so, we got to get PT and help them move to reduce the duration of delirium. And F is family engagement and empowerment. This is also part of what we can provide as a SEAL psychiatrist. I'm going to go into a little bit of the details in each one of them the next few slides, but multiple studies shows with thousands of patients actually shows that the A to F bundle decreases the likelihood of hospital death, reduces delirium and coma days, reduces physical restraints, reduce ICU readmission, and reduce discharge to nursing and rehab facilities. And so A to F bundle should be practiced in most ICUs. Sometimes, I think folks get busy and whatnot. So I think as a CL psychiatrist, this is something that we can continue to, recommend our critical care doctors to follow whatever we are seeing, just even one patient, to decrease all of this together. Okay. So let's talk about A of the A to F bundle. A is assessing, preventing, and managing pain. Now, pain itself is such a huge topic. I'm not going to be able to cover it within this section, and I think Dr. Jimenez is going to talk about pain, in the later talk. So, he's the expert in it. But just going to talk about briefly, especially in the ICU setting, in this slide. So, for pain assessment in patients who are suffering, who are in ICU, the gold standard is self-report. That is the gold standard. But in patients who are intubated, sometimes they're not able to, or sedated, sometimes they're not able to say how much pain they are in. So they developed what we call behavioral pain scale, and you can see from facial expression, upper limb movements, as well as the compliant of mechanical ventilation. And you kind of score them, and you'll see how much the patients are suffering from pain. And the pain treatment is, it was surprising. The first line is opioids still. As a CL psychiatrist, we try to avoid opioids as much as possible because it is deliriogenic. But we also know that pain itself can cause, or be precipitant of delirium as well. So we got to find that right balance. So actually, what our critical care doctors are recommending is to try to come up with an adjunctive pain medication to lower or at least minimize the opioids pain medications as much as possible. So as an adjunctive, they're recommending acetaminophen, ketamine, neuropathic pain medications such as gabapentin, pregabalin, sometimes carbamazepine. I don't really like to use carbamazepine too much because of its drug-drug interaction, as well as acetylcholine 50, and nifapem. That's not in US, but it's like a dopamine norepinephrine serotonin reuptake inhibitor. It's been used, I think, in Europe and some other countries, but that's not in US. I'm not sure exactly why. And surprisingly enough, before we use this medication, we also, of course, the patients are in ICU, so we have to know, we can't really use acetaminophen in patients with liver failure, neuropathic pain, such as gabapentin, pregabalin. You got to, be careful in a patient with renal failure. And ketamine, we have to, be careful because it has a psychomimetic side effect. So a patient can be a little more edgy and can tip them over to delirium. Okay. So interestingly enough, the consensus is they are not recommending lidocaine and NSAIDs actually. So I was actually surprised by that. So NSAIDs, lidocaine don't really show too much of. It doesn't really help that much as an adjunctive for opioids. And NSAIDs, I think they're recommending against it because of its kidney side effect. I'm gonna move on to the letter B, both spontaneous awakening trial and spontaneous breathing trial. I'm not gonna talk too much about this because, as you can see here, I let our critical care doctors kind of handle this, but I just recommend our critical care doctors, hey, have we thought about using trying to lower the sedative drips? Have we thought about trying to have them breathe on their own a little more? Because I don't want to, because there's all this different things that I'm not too expert in, and I let our respiratory therapists and critical care doctors handle it a bit. But it's always good to mention whenever I go see a consult and they go, hey, I saw this patient for 3 days in a row and they're deeply sedated for all the 3 times. What's going on? Can we just lower the drips a little bit, or can we try to have them breathe on their own a little bit to see where they are? So and then they can give us a reason like, oh, but their FiO2 wasn't that great. They're still on pressors and things like that, so we can't really do it. Then I'm like, okay, but sometimes we're like, oh yeah, sure, why not? Let's give it a try. So it's something good to think about, or kind of remind them whenever we go see a patient who is sedated in ICU. The next is choice C is choice of analgesia and sedation. I really like this cartoon because when we go into the ICU and the patients are all sedated, are they sleeping? No, right? Because in order to have them actual good sleep, you got to have sleep cycle. We have to go through a sleep cycle, but when they're sedated with a lot of the medication that we use, they're really not. And the medication that actually used to have them sedated, we interrupt their sleep cycle. Actually, study shows, right? So we go there and it's like, oh, he's pretty resting comfortably, but they're really not. No, they're not really sleeping, and something's we're just putting them in medication-induced sleep, sedation. And out of all the drips, however, I'll talk about it a bit later. There is one drip that I like to use as, I recommend as much as possible. But before I talk about that, I think this is another lingo that the critical care doctors use and we should be familiar with is RASS scale. It stands for Richmond Agitation Sedation Scale. It's a 10-point scale, -5 to +4. And -5 is unarousable, almost like a comatose state, to +4 is super combative. And we try to be adhere. And usually in ICU settings, the nurses will document what the RASS score is per hour. And so when you go to the flow sheet, it will show how agitated the patient was or how sedated the patient was. So we always try to aim from -2 to 0. And in order to achieve this, we need to carefully choose sedatives and analgesic medications, and we need to consider dose, titration, and discontinuation as needed. There are studies actually comparing different sedatives, and there are 3 main ones that have been published. It's called SATCOM study, MENS study, and MENS 2 study. They're all done by our critical care colleagues. The SATCOM study actually talks about, or they compare dexmedetomidine and midazolam. And dexmedetomidine is shown to by far, works best, by far works better than midazolam does for days alive without coma or delirium. The MENS study was comparing dexmedetomidine and lorazepam. And again, dexmedetomidine shows that it's favorable. The MENS 2 study is actually comparing dexmedetomidine and propofol. That was the most recent study. It was also done by Dr. Wes Eli at Vanderbilt. And it actually shows that, there isn't too much difference between dexmedetomidine and propofol. However, I think I would still try to use dexmedetomidine as much as possible if we can. The reason being is dexmedetomidine has actually shown it's a bit different, right? The mechanism of action is alpha-2 agonist, whereas propofol actually acts more as a GABAergic mechanism. So different studies actually show that dexmedetomidine helps with sleep, increasing the stage 2 sleep. Actually, they did a polysomnography on patients who are receiving dexmedetomidine, and that actually showed that this is one of the best medications, at least that we have on our tool to help patients get sleep in ICU. And not only that, dexmedetomidine also showed some promising results in terms of pain management in adjunct to opioid. The reason that they're thinking the mechanism of action for that is it helps with increasing the inhibitory synapses within the dorsal root of the spinal cord. So it actually helps with patients, decreasing pain, can help with sleep, can help with, reducing delirium and so forth. So if you have to choose, I think I'm going to, choose dexmedetomidine as one of my choices of analgesics. But of course, it's, you have to work with our acute care doctors because sometimes patients' pressures, blood pressure might not be, they might be too soft for them to be on dexmedetomidine. So they have to try different sedative drips. Okay. And E is early mobilization. And as you can see from here, we got this patient who's probably on ventilator, but he's still able to walk. I had a patient, in critical care who was, was suffering from COVID, who was on vent, who was on ECMO, but they were able to try to get him around, to move them around to the PT. And it took like 5 nurses, 3 physical therapists, but she was able to get out of bed and she was able to do it. And it was amazing to see. The reason why I kind of emphasize, and it is part of early A to F bundle, is out of all the A to F bundle, it's the only one that actually shows to actually shorter duration of delirium. So all the medications we try to use, everything else that we try to do doesn't really help with the shorting, reducing the duration of delirium, but the early mobilization does. So that's very, very important. And we should really try to see if we can get PT, come and assess if the patient is safe to do so, to participate in PT and move around and be out of bed as much as possible. It also, decreases length of stay, improve functional outcomes, especially after patient leaves the hospital. And it also, shortens the duration of mechanical ventilation. I didn't really talk too much about the family engagement because I think, as psychiatrists, we're already all aware how important it is to involve family in patients' care, to get collateral, to understand who the patient is. And as I said, understanding the patient as a person and and approaching in a holistic care rather than just like assessing the numbers, assessing the pH, if the patient is acidotic and whatnot. Okay, so that's also very important. I left this for last because I think this is where we would get consulted the most, and we can help out with our ICU colleagues most. Is the D of the A to F bundle, is delirium prevention, assessment, and management. We'll briefly touch upon delirium prevention as well as assessment or screening. So delirium prevention, we all know we want to try to make sure their wake cycle is intact as much as possible. Try to reduce anticholinergic medications, try to reduce benzos, try to remove lines if not needed. But I want to try to focus. So I want to try to focus a little bit more on some of the assessment or screening tool that we have, the Chem-ICU and ICD-SC. And this is another language that I think we should remember after this talk. The Chem-ICU has been developed by Dr. Wasila again at Vanderbilt University. And it just kind of goes down this stepwise function here in the flow sheet. I'm not going to go into details of how to do it. I think we all know how to read that and see if we can if the patient tests positive on Chem-ICU or not. But one thing I want to focus on is this here, the attention test. Because patients who are sedated and intubated, sometimes, one of the best attention tests I like to ask in patients who can talk is the months of the year backward. But they can't do that. And, and for those patients, we can ask them to squeeze their hand whenever they hear letter A. And you can remember either Save Heart or Casablanca. Those are 10 letters, 10-letter words. And if the patient misses 2 of them, then it's a positive sign. Okay, then it means the patient is inattentive, and you can move on to the next screen. And that's one of the best. I use that all the time when I see patients in ICU to assess for their attention. Okay. Another screening tool that we can use is ICD-SC. Again, I'm not going to go into too much about how to score this. We can all read that. But you can see from here, they look at the RAS score, and even for inattention, they have the Save Heart for them to squeeze. The same thing as the Chem-ICU. asking the patient to squeeze our hand whenever they hear letter A. But one thing I want to talk about here is the subsyndromal delirium. I think subsyndromal delirium, the word, and they kind of came up with the ICD-SC. I think it was coming from this. It kind of helps us to see patients as delirium as not just black and white, but it's more of a spectrum. Patient might not be grossly delirious when we see the patient at first, but they might be, whenever we go and see the patient, they're like, oh, I think the patient is a little delirious, but our primary teams are like, no, they're not. What are you talking about? So I think the subsyndromal delirium, the diagnosis kind of came up from this, but it's kind of important to understand how to score this and see if the patient fits into the criteria. Most of these are done by our nursing colleagues who are in ICU, preferably every 12 hours, but that doesn't really happen. So we can always ask them to see if that, if they can, do it more regularly. So yeah, and of course, these are screening tool, but the gold standard assessment is a clinician, CL psychiatrist going there and us actually assessing if the patient is suffering from delirium or not. Okay. Let's talk about management. Yeah. So this is Maldonado's, Dr. Maldonado's paper on pathophysiology of delirium. I spent a year with him, and thankfully with the COVID, he didn't go anywhere to give lectures, so he actually stayed on campus and was able to work with us a lot. I spent a year. I still don't know a lot of it, but so I had to actually dumb it down for myself in order for me to understand it better, and in order for me to actually use some clinical. Use it for clinical purposes. Okay, so I'm going to talk a little bit more about these things where increased norepinephrine's, increased dopamine, increased the glutamate, and of course at the center of it we have low acetylcholine, right, for the patients with delirium. This is basically talking about the neurotransmitter pathophysiology of patients suffering from delirium. Okay, so let's talk about this. How we can actually manage delirium. So we are not treating delirium, right? Everybody knows that. The treating delirium is treating the underlying medical cause. I would kind of approach it in a more of a, managing or at least symptomatic management of delirium as a skilled psychiatrist. So as you can see from the previous slide, we're thinking that there's an increase of dopamine in patients suffering from delirium, and the patients can present in a very psychotic way. They have hallucinations, auditory hallucination, visual hallucinations, of course, paranoia. I remember, I went to go see a patient, and she thought that I was Viet Cong. I am Korean, so I'm not Vietnamese, but she thought I was Viet Cong, and she was very, very afraid. And she kept saying around 4 p.m., people are going to come and kill her, and you guys are going to come and kill her. She was floridly delirious. 2 days later, she was pleasant, like one of the most pleasant lady ever. And she said, I remember saying that, and I'm very, very sorry. But for those patients, I think there is a little bit of a dopamine, hyperdopamine within her brain, and for that, we're going to try to target it with antipsychotics. Now, let's talk about two studies. Actually, Mind USA study that was done by Dr. Wes Eli and recently published in 2022. At AID ICU. So both are randomized placebo-controlled trial and multi-site. The Mind USA is the one that talks about the Haldol versus placebo versus a Geodon, and the AID ICU is the one that talks about the Haldol versus placebo. So for Mind USA, I think and both are published in New England Journal of Medicine. The Mind USA, I think, is a great study, but as we all know, that study has a lot of hypoactive delirious patients, and the protocol was you give antipsychotic, the Geodon or Haldol, if the patient is hypoactive or delirious. If they don't improve, then you give another, antipsychotic. I don't think I'll be, doing that as a clinical clinician. So, it's a good study, but the results, I have some doubts. But one result that I got out of that is, hey, the QTC prolongation with IV Haldol, and that much compared to placebo. So IV Haldol is a great medication to use if we need it be. And the the 8 ICU is actually, I think they were seeing a lot more hypoactively delirious patients. So it's more applicable to my clinical practice. But even that, I think there was some issue there because the primary outcome that they were looking at is I do believe is days alive and out of the hospital. It's not about the psychotic symptoms a patient might be suffering from, how many times they had to reintubate the patients because the patient was becoming so delirious when they were lowering the drips and things like that. And the secondary study actually showed the all-cause mortality is lower with Haldol. So I would still use Haldol if needed be. So, and also in that study, the QTC prolongation wasn't really statistically different, even we were using IV Haldol, compared to placebo. So I'll be using IV Haldol. I use IV Haldol a lot, and there are 3 different antipsychotics that I like to. I usually use. First is IV Haldol. Second is quetiapine, and lastly, olanzapine. I don't like to use olanzapine that much. I mean, it's my personal preference because olanzapine itself is very anticholinergic medication, and we're trying to reduce delirium as much as possible. We're trying to take away all the risk as much as possible. So why don't we use Haldol, which is just a pure dopamine blockade, and utilize it to target some of their psychotic symptoms. And if we need to use some medication to help them calm down a little bit, sedate them, because olanzapine does that. But I think that they do it from the antihistaminic property. So why don't we use the quetiapine? Quetiapine is also very antihistaminic, but less anticholinergic than olanzapine itself. So we can use quetiapine or Haldol. So those are my go-to antipsychotics if I have to use them. And as I talked about QTC prolongation, there's recent published paper from Scott Beach at MGH, and he was basically saying that, hey, you're worried about QTC prolongation from IV Haldol. Actually, we shouldn't be using any other antipsychotics. That's the one takeaway that I had from the paper. So that's of course there is higher risk of prolonging QTC with IV form, but we like to use IV form of Haldol than PO because it causes less EPS side effect. Okay. But next is the neurotransmitter that I want to talk about is the glutamate. And there's increased glutamate within when the patient suffering from delirium. That kind of can show in symptom-wise, it can show a little more hyperactivity, anxiety, restlessness, confusion, and so forth. And the drips that targets the increased glutamate are propofol and ketamine. Propofol acts in more of a GABAergic way, so it's the opposite of glutamate. So it's trying to reduce glutamate by increasing the GABAergic tone within our brain. But ketamine itself is an NMDA receptor antagonist, which is basically blocking the glutamate binding site. And ketamine can be used in a low dose for pain, but also can be used in ICU setting for sedative medications as well. If you put it high enough, they're gonna be sedated with ketamine. And so, I want to actually go back to the first example that I gave about one of the first consults that I got when I started my fellowship about patient. We were trying to lower the propofol, and the patient is getting really, really agitated. For that patient, they tried to use a lot of different antipsychotics as well, and it wasn't really working. And until we actually added on valproic acid for managing the delirium, because because he was controlled pretty well with the propofol, and when we had the VPA and we titrated it up, we were able to lower the propofol slowly, but he was off of propofol and was able to converse with us and able to be out of ICU. And after he got out of ICU, we were able to start titrating off the valproic acid as well. But valproic acid falls under the glutamate targeting the glutamate system as well. And there's a lot of different mechanisms of actions, such as targeting the sodium channel, also enhancing the GABA activities. But I will put that under as targeting the increased glutamate within our brain. Okay. But valproic acid, we have to watch out for using it, especially in ICU setting, because patients are in ICU because of multi-organ failure. Patients with liver failure, we got to be careful of using it. And for transaminitis, I, tend to still use it if their transaminitis is not that bad, and if the synthetic liver function is intact. If meaning the INRs and PTs, if they're elevated and the transaminitis is also elevated, and there's some sort of liver issue, then I wouldn't be using valproic acid, because it means that it's not the valproic acid might not be cleared that fast, and it can be a toxic thing for the patient. Another thing to watch out for when we're using valproic acid is albumin, and the patients tend to actually have low albumin, especially in ICU setting for malnutrition and so on, because valproic acid, the toxicity as well as the clinical effect is actually coming from the free valproic acid. It's not coming from the total valproic acid. We get the total valproic acid level because it's easier and it's faster for us to see it, but we have to, the free valproic acid is the one that we actually have to worry about. And in patients with low albumin, there will be increased free valproic acid. And also the free valproic acid, the higher the free valproic acid, it is known to, it is correlated with lowering the platelets and thrombocytopenia. Which brings me to the next thing that we have to watch out for when you're using valproic acid is patients with active bleeding and platelets are going down. I wouldn't be using valproic acid because we don't want to hasten their worsen their bleeding. Okay. And some drug-to-drug interaction that I would be watching out for is because the patients are in ICU, they could be under septic shock or sepsis. They, our ID folks, for severe infection like to use meropenem quite a bit, or carbapenems, all the penems. What it does to valproic acid, that it literally chews it up. It enhances the glucuronidation of valproic acid, so the VPA level will go down, and there'll be almost like nil level if you try to get the level after valproic acid after meropenem is started. And actually, a lot of ICUs have a warning sign when they're recommended to use penems when the patients have valproic acid, because sometimes they're on it for seizures, right? So it might actually induce seizures, and when they give meropenem, so that's something that we have to watch out for. And we should talk with our infectious disease or our intensivists to see, hey, can we use different antibiotics to help the patient, or if not, then we have to use some other psychotropic medication that we have. Another medication that I like to use is either gabapentin or pregabalin in the patients who might be in more of an anxious distress, as in subsyndromal states. And I tend to use pregabalin a lot more so than gabapentin, because pregabalin actually is shown to have a faster onset of action because of its absorption. It gets absorbed linearly, and also if you think about it, in patients who are in ICU, don't know how their digestion is, you don't know how their absorption is, especially with the edematous gut, and when patients are in ICU for quite some time. I would like to use pregabalin to kind of fight that. And pregabalin, and also it can be used as a PRN, better than gabapentin because of its faster onset of action too. Okay, but also you have to think about the caveat that in the patient, if we're in ICU, a lot of them suffer from kidney injury, so we have to renally dose our gabapentins and pregabalins as well. The next neurotransmitter that I want to talk about is norepinephrine. And the drip that targets the norepinephrine is dexmedetomidine, the one that I called the Precedex, the one that I talked about in the previous slides of choosing sedative drips or analgesic drips. And dexmedetomidine works as an alpha-2 agonist. We have to be careful of using it. I like to avoid MAP falling below the blood pressure, MAP mean arterial pressure falling below 65. But we can talk with our intensivist to see if we can use it, and if they're worried about soft blood pressures, they might not want to use it. But another thing that we can help out is patients are getting agitated when we're lowering the dexmedetomidine. I think there was like this talk, or somebody was talking about like dex withdrawal. I wouldn't think it's a withdrawal. I think it's just patients are delirious, and as we're lowering, just like how we're lowering propofol and patient gets delirious and they get agitated, that's just like how things are when we're lowering dexmedetomidine. So that's one thing to think about. And in order to lower the dexmedetomidine, lower the drip, so the patient can be out of the hospital, out of the ICU, we can use other alpha 2 agonist medications such as guanfacine or clonidine. I put IGALMI there. IGALMI is the newer form of dexmedetomidine. There's a new study out that's been used to agitations in bipolar patients. And so it's a sublingual form. It's like a little patch, like a Listerine patch. You just put it on there, and it kind of melts, and it gets absorbed through that. I think that's a potential. We can actually use that to kind of have the patient be off of dexmedetomidine as much as fast as possible. Okay. The next medication that can use is clonidine, but I wouldn't use clonidine in ICU setting if we can use guanfacine, because clonidine, out of all the three alpha 2 agonists, the dexmedetomidine, guanfacine, and clonidine has shown to decrease the blood pressure the most. And patients who's in ICU, usually they're in ICU because of either shock or low blood pressure. So I wouldn't be using clonidine as a bridge from dexmedetomidine. Okay. I forgot to mention about dexmedetomidine. How I said dex is shown to help with some sleep in ICU. We can actually use dexmedetomidine as there's this protocol, like a dex cycling protocol. So we begin, dexmedetomidine, we start titrating up so that patients' RASS is between 0 to -2, starting around 10 p.m. and around 4 a.m., 5 a.m., we start lowering it so that their RASS comes back up to 0 to about maybe +1 at max. So it kind of tries to help them sleep a little bit better in ICU setting, and even in patients who are not really, sedated or anything like that because they can't really fall asleep. Poor sleep is also known cause for delirium. So, or precipitant of delirium. So we have to, take that into consideration. Okay. Oh, one thing though is very expensive. Dexmedetomidine is very expensive. So, a lot of ICUs don't want to use it too much, but I mean, that's one of the best drips that we have. Regarding sleep, we have some melatonin and Ramelteon. A lot of studies shows that melatonin don't help that much. I mean, but if you go to ICU, how many ICU beds do you see without any windows? Like, I would go delirious if I'm there for 2 days. So it's kind of hard to do actual full studies on that. But Ramelteon has shown some promising effect. Another medication that we can actually add on these days is orexin antagonist. Orexin or daridorexant. The daridorexant is the new kid on the block. It has shorter half-life, so we can actually use it. I think more. I think in a more ICU setting, or even in a hospital setting, to help sleep-wake cycle. Okay. So where do we go from here? So that's the next slide. So I want to talk about post-intensive care syndrome briefly. It's in an outpatient setting. As I talked about it, a lot of patients are suffering from mental health. About 30% suffering from depression. About studies show about 10 to 50% suffer from PTSD and acute stress. One of the symptoms they'll tell you is like, oh, I am very afraid to go back to the hospital. I don't know why. It was very, very scary things that was happening. I think about 2 years ago in 2020 at SLP, we had a general surgeon who was suffering, who got a shock, and while he was operating, had to go into ICU within the same hospital, in his own hospital. But he was talking about his delirious episode, and he was telling us how scary it was, and he, I think, was describing some of the PTSD, mostly got acute stress symptoms, and he had a hard time going back to the hospital to work. This is a real, even for surgeons or us who know what delirium is, it's scary. And can you imagine a patient who have no idea what delirium is, and after they get a surgery, they wake up and they're hearing all these voices, hallucinations, and paranoid. It could be a very traumatic thing. And as I said, patients in ICU are very, very vulnerable. Okay. And the next thing in next part in post intensive care syndrome is cognitive impairment. We all know patients suffering from pre-existing cognitive impairment. They can get worse. Or delirium can hasten their cognitive impairment. Okay. In physical impairment in patients who are in bed for a long time in ICU, they can suffer from critical care myopathy, neuropathy. They present with muscle weakness and nerve problems. They don't have the physical function that they were able to before going into ICU. So that's also something to think about, and try to involve PT as fast as we can. Okay. So now, where do we go from here? This is it's like a new, relatively new field in CL psychiatry. And in SLP, we have the special interest group for critical care psychiatry. A lot of great minds in CL psychiatry there. Dr. Stern, Dr. Muskin was also there, Dr. Beach, Dr. Maldonado, Dr. Scher. Everybody, great minds are there. We're trying to promote this critical care psychiatry, and then do some studies to promote this field. And a lot of different academic institutes have already established, critical care CL, like ICU specific teams. And of course, there's one at Stanford. I think one is Brigham, VCU, UT Southwestern. I'm not sure if there's one in Vanderbilt, but I think they do a lot of, study with, our critical care colleagues there. But I think it's important to think about, and especially in academic institutes, to implement that, or not even academic institutes, just any institute. We should think about that, trying to implement the A to F bundle and help implementing the A to F bundle in critical care. Okay. That means that we need to continue to promote critical care psychiatry. And lastly, I was able to, because I'm a speaker here, we're creating a CL psychiatry fellowship here at Weill Cornell, and I want to try to make sure that we grow this critical care psychiatry as much as possible. So if any of you know any residents who are interested in critical care psychiatry, please send them our way. We would love to help them train and learn about critical care psychiatry. Okay, and with that, thank you very much for your talk, for my talk. Okay.
Yeah, I do think it's a much needed area of potential growth. I was just wondering about the one point you brought up in the last slide about post-ICU care syndrome. I know I was always struck every time I read literature about sometimes 60% delirium, PTSD in patients with respiratory failure on ventilators. And I was also struck that in 10 years of outpatient practice in the hospital, I've never seen one of these patients. So I wonder, to feel what are these? Is this a group of patients suffering somewhere that are not identified and fully treated, and what your thoughts about how to identify these patients? And I know it's often not just a traumatic experience, but also these horrific thoughts of a Viet Cong coming in, and it didn't happen, but they were haunted by this.
Yeah, that's a very good question. I think we're missing a lot of these patients, to be honest with you, because when I spoke with Dr. Lieff here at Lindsay Lieff, who's a critical care MICU, head of the MICU. She runs a post ICU clinic, and she was saying they do screening tools and stuff like that, and patients suffering significant amount of symptoms from PTSDs and depression, and she doesn't know where to send them to, because everywhere is full. So I think in order to catch these patients and really help them to not get worse, I think we should probably start as almost like an embedded outpatient clinic in our critical care setting, and which I think some institutions are thinking about doing. We have an embedded, CL psychiatrist in oncology clinics and things like that. So you can think about creating like an embedded outpatient CL psychiatrist into this post ICU clinics. And I think that's the way to approach and make sure we catch these patients, underrepresented patients. Yeah. Sorry. So a lot of folks say that because gabapentin, because of the word GABA, they think it's GABAergic, but gabapentin do not work on the GABA receptor at all, right? It as a calcium channel blocker of presynaptic glutamate neurons, so it prevents release of the glutamates. It has nothing to do with the GABA. So that's why it was under the glutamate neurotransmitter. So I don't think gabapentin actually causes worse delirium. It actually would potentially help. Okay, good question. So gabapentin, I would probably start with 300 TID. But as I mentioned, I use gabapentin in an outpatient setting, but in inpatient setting, I think I would stick with pregabalin because, as I said, because of a faster onset of action. And I would do I think it's about 1 to 6 conversion. So a 300 milligram, 300 TID is like the initial dose. Then, it's about 50 milligrams of pregabalin, 50 TID. So that's how I would approach it. Okay. Dr. Baltha, you had a question?
Oh, yeah, no, I'm just thinking if I should even ask it, but I mean, at a place like Stanford, there's an established culture of psychiatry helping ICU, which comes with respect, I guess, help acceptance. And I feel like ICUs have a unique, most ICUs I've been a consultant in, there's a unique sense of like, we've all had our recommendations not been implemented, but there's, I guess, what can you speak on establishing that relationship, that working relationship when you come in as the psychiatrist? And I don't know, I guess I find that more often than not, it's like parts of the recommendation that then turn into something else, and then 3 days later, it's a completely different plan that we discussed. But it makes sense because it's nice.
Yeah.
So what's your experience been in terms of establishing a service?
So the question was, what's my experience been in terms of establishing a service? So as you said, I was actually, I would say, privileged to go to train there at Stanford because it was already established, right? But here I'm trying to establish it, and that's a very important question because these academic institutions or any ICU institute, they have their own culture and they don't want to change it because ICU doctors they want to have control and they are in that field because they want to have a good control of the patient, right? So one way that I want to approach is, that's why I want to talk about the lingo, the language here. When we start talking about A to F bundles, and when we talk about, hey, the RAS is a little too the patient RAS is a bit too high, and can we do SPT, SAT? They'll be like, what you talking about? I thought you were a psychiatrist. So that actually helps when we start talking their language. When we go there and we just say, hey, we want to try to help as much as we can. The way that I try to approach in our CC, I had a meeting with our CC, cardiac critical care unit head yesterday, and the way that I was approaching it was, hey, listen, I'm not here to. I told them I'm not here to change cultures and things like that. Just want to make sure that I want to help to reduce the length of stay and reduce patient on intubation time. All the money talks that all the things that they want to hear about, which are all true that we can actually offer. And then they're like, okay, sure, come on in, let's give it a try, let's see what we can do. And being present, being available for them, I think that's one key. I would probably, in the beginning, I'll be probably, if we start implementing this and we get more consults in, I'll probably be there almost every day, seeing a patient and just going by and seeing how they are. And also another key thing is be friendly with the nurses. The nurses will make it or break it for you because you have a really good relationship with a nurse, and they'll they'll tell you, first of all, they are the best source for the information of how the patient has been doing for past 12 hours or 24 hours. And also they'll be the ones telling, the attendants, even critically is like, hey, let's listen to Dr. Bata. He is really good. He is going to, he got this agitated patient controlled really well. It's like, okay, all right, let's give it a try then, So you're going to kind of buy yourself in there. It's almost like, it's like, you got to be a salesman, or a saleswoman, really. Yeah, no salesperson. Sorry. Yeah. Okay.
Well, thank you so much for that great talk.
Thank you.
While we are setting things up for the next speaker, Dr. Bata is going to do our first raffle.
Yes. Okay. Thanks everyone for setting it up. Dr. Angelova, Dr. Rodak. Someone went from Jackson Heights to where did all these prizes come from? Astoria to Long Island City. So they've come a long way. We're excited to give them out. I think the best way to do this would just be pick a basket, because some of the books, some of y'all might have already. So I think feel free to take a peek. And if you haven't got tickets already, the Venmo is here. It's my first name and last name put together. It might ask for my last 4 digits of my phone number and 6497. I can repeat that later. All right. So first winner is 831029. So I guess 29. Oh, nice. Congratulations. So yeah, go ahead, pick a basket. Do like a couple more. 22. Oh, nice. Diego. We'll do maybe one more. 34. All right, Gabriella. Congratulations to all the winners. All right, one more. 30. Oh yeah, 6497. Yeah. Is that you again, Gabriella? 30? It's 831030. All right. Oh, okay. Okay. Might have a few repeats. 4. That might be me. Oh, all right. 4. Yeah, just 4. I think that, yeah, that's me. Okay. All right. Thanks, everyone.
Great. Thank you, Amit. And congrats to all of our winners. So our next speaker, Dr. Javier Jimenez, is Director of Consultation Liaison Psychiatry and Chronic Pain Consultation at Long Island Jewish Medical Center. He completed psychiatry residency at the University of Pittsburgh Medical Center, followed by a psychosomatic medicine fellowship at Massachusetts General Hospital at Harvard Medical School. Prior to joining Northwell Health 2 years ago, he worked at the Cleveland Clinic for over 7 years and served in a number of embedded medical psychiatry roles in departments ranging from epilepsy, spine orthopedics, dermatology, bariatrics, and transplant. He also served as the director of the Chronic Pain Rehabilitation Program and Department in the Neurological Institute. He is boarded in pain medicine as well as psychiatry and addiction medicine. He currently is on the Northwell Opioid Task Force Committee and runs a chronic pain consultation service, offering focused consultation for certain chronic pain patients with psychiatric comorbidity. His areas of research and academic work include chronic pain, central sensitization, pain psychopharmacology, functional somatic syndromes, medically unexplained symptoms, abnormal illness behavior, and integrated care models.
Hi, everyone. Thank you so much for the introduction. I'm very sorry that I can't be there in person. SLP has a special place in my heart. When I was a resident at St. Vincent's in Manhattan, I remember going as a trainee, and I'm sorry that I couldn't be there. Lots of coverage issues on my end, so I have to take care of that first. I'm going to start flashing up some slides here. Let me see if I can share my screen. Here it is. Please wave at me or make some kind of signal if you cannot see the slides. Let me just check 1 second. It looks like I'm still, yeah, 1 second. Okay, there I am, or my slides, I think. Again, stop me if you can't see or hear something. I'm going to go ahead and start. As mentioned, I'm at Northwell now about 2.5 years here, but prior to that, I was working in chronic pain at the Cleveland Clinic. I started there as a bread and butter, prototypical inpatient CL psychiatrist, and then got sort of sidetracked, thankfully, into pain management. And the reason for that was there was a wonderful psychiatrist who had been running a chronic pain rehabilitation service for many years, and he was retiring, and he wanted somebody to, cross over and take over his service. And initially I was very intimidated by the idea of doing pain management. And then I learned what it was really about, which is what this talk will be about. I eventually, as mentioned, became pain medicine boarded and addiction medicine boarded in this context. So that's a little bit of the background as to how this came about, and another example of an unusual CL psychiatry role. I guess that's the theme for today's talks. So as mentioned, my journey to this point, just in case there's any trainees or early career docs wondering about how one makes this kind of leap, I want to preface it by saying I was always interested, as mentioned in my intro, in abnormal illness behavior, whether that was factitious disorders, malingering disorders, personality disorders, conversion disorders. I think you kind of have to have a tolerance for that world if you want to work with chronic pain, because at the end of the day, chronic pain can be classified as a functional neurological disorder of sorts, and those patients share many features with those of conversion and factitious, et cetera. So there has to be some ability to work with trauma, with complex behaviors, with comorbid addiction, et cetera. And so that was sort of the beginning of my interest in that. And then, as I mentioned, I was invited to run that service. And in that service, or in that role at the Cleveland Clinic, I had 3 main roles. Currently, I have only one of these, and I'll talk more about this later. But in the CL setting, which is most relevant to those here today, I was doing these so-called pain psych consults, which is really a blend of psych consult, CL, plus pain management and addiction evaluation. So these are the individuals who, for example, were not very linearly pain management, psych, or addiction, and could benefit from some cohesive link between these. The cases that might be ping-ponged from one service to another. Pain management sees them, they call psych, psych says this is all pain. Those types of patients, sort of bridging it all together. The second role that I had was as the medical director for essentially what was a day program or an intensive outpatient program for chronic pain and all of its comorbidities. So this was a multidisciplinary team that would, for 3 to 4 weeks, put people through physical therapy, psychological therapies, detox from controlled substances, complex psychopharmacology of pain, which I'll get into, and other interventions. And they did wonderfully with this sort of intervention if they went through it. And I was medical director for that and worked within this sort of grid at different points. So you can think of a psych IOP and the role of a psychopharmacologist in that capacity. And finally, individual patients that I might see in clinic who might not need that kind of robust level of care is, for specialized consultations, or even following them up chronically, managing them with either outpatient detoxes off of opioids, maybe Suboxone management, things of that sort. This is actually what I currently do in small fashion at Northwell, but my hope is to expand into the first 2 bullets as well. So again, the question of whether CL psychiatrists should be managing pain should be addressed. Firstly, I want to clarify, again, this is more about chronic disabling pain. I am not a proponent for psychiatrists getting involved with perioperative pain management or acute pain. I don't think that's really our role. Of course, sometimes maybe we can address some of the comorbid anxiety and distress associated with acute pain, but not so much the pain itself. Analgesia in the classic sense should be left to the anesthesiologists and pain interventionalists. Secondly, if you recognize and identify psych comorbidities which are rampant in this population, then you have a good opportunity to help them, not only with those comorbidities, but with the pain itself. And obviously, psychiatrists are better suited at that than anesthesiologists or other pain docs or even neurologists. Thirdly, I would say that CL psychiatrists are actually pretty adept at psychopharmacology and at detox. We're constantly cleaning up polypharmacy, right? We're constantly doing alcohol and opioid, tapers. We're constantly looking at too many meds in the way that are clouding mentation and producing all sorts of problems. So I think actually this is one of the most important skills that we have. And within psychopharmacology, I would say that because we don't have in CL, inpatient CL, many FDA approved treatments for what we see, agitation, delirium, etc., you actually can make a leap towards chronic pain where, by and large, we don't have that many FDA-approved treatments either. And so that kind of experimentation, careful and evidence-based, but nonetheless non-FDA-approved off-label psychopharmacologic experimentation applies very relevantly to chronic pain management, as we'll see. Fourthly, I think within psychiatry, the CL group is clearly more attuned to medical issues. They're closer to the lexicon that is used by other providers. They understand, hopefully, medical matters more than other psychiatrists. We like that world, or we should if we're in CL. And so I think we're best suited at talking about neurologic phenomenon, medical phenomena, et cetera. I appreciated Jeff's comment earlier about understanding the lingo of your stakeholders. The same applies here. The stakeholder here might be your patient, but it could also be, neurologists, pain management doctors. Understanding this jargon and understanding something about how pain works and doesn't work can be very valuable and validating to the patient. So these are some of the reasons that I suggest actually that more CL psychiatrists get involved and not be terrified of this, to practice an approach, because you already have some built-in inclinations and skill sets that can help. Let's get into the meat of the matter, though. I want to briefly go over a few things. I didn't list objectives for today, but one of them is to review pain and chronic pain specifically, then get into sort of pain psychology, if you will, briefly, because it's very important to understand people's pain experience. That's a huge segue or bridge towards why psychiatry might be relevant in this space. Then get into some actual psychopharmacologic interventions, and then wrap up and hopefully answer some questions. So let's define pain. First of all, we should remember that it's not just a physical sensation or sensory phenomenon, but also has an emotional experience attached to it. This is not my definition. This is a definition from the International Association for the Study of Pain, a consensus group that actually does, lab research and things of that sort on pain. It's well, vetted and demonstrated that pain is not simply a neural sensation. There's also emotional or psychological layers to it. And note also that it's associated with actual or potential tissue damage. So of course it's going to hurt when tissue is being lesioned or damaged. But in addition to that, there's psychological, and physical pain, even with the idea or the anticipation of pain. And this is important again for psychiatry, because if patients are walking around anticipating pain, then we can do something about that, right? It's not even tissue damage itself, but the potential of repeat tissue damage, which, if you're already listening, sounds a little bit like re-traumatization. And we're going to get to that idea of a PTSD model being, or correlate, as being very valuable in chronic pain management. A couple of other notes here, just a reminder that, pain is not a bad thing. It's evolutionarily adaptive. It's supposed to warn us against, tissue damage and things of that sort. So remember that in your chronic pain patient, however, it may have gone haywire and it's excessive in terms of the warning signals. And that we should keep our eye on the emotional and psychological reaction to the event that may have started the pain, even if it was years ago, that psychological and emotional layer is very critical. So, just to look at chronic pain management currently as a cross-section only, I want to remind everyone on how that sort of failed us and contributed to things like, the recent push for analgesia in a vacuum or decontextualized analgesia, if you want to call it that, which of course propelled part of the opioid crisis. We do this sort of, 0 out of 10 sort of analgesia thing, and it's natural because the patients are saying, I hurt, and that's their agenda, right? That's what they're screaming. And so it's very well intentioned and normal for any physician, pain management or us, whoever, to want to do something about that pain. And we should try. However, oversimplifying it as just a simple analgesia problem, particularly in your chronic pain patient, is problematic. You get back to only your pure analgesics, again, opioids and whatnot, and then you're back to square one, the problem that we all faced recently with our epidemic. So we need to consider a broader understanding of pain. And to start, we should really define what chronic pain is to differentiate it from acute pain. So chronic pain is defined as pain lasting greater than at least 3 months. Some definitions are 6 months from acute incident, insult, or injury. So that's very different from acute perioperative, pain or pain flares from acute injuries. Many individuals will heal nicely, will not have chronic lingering pain after the 3 to 6 months, and yet there are some who do. So the question is, what's propelling that or maintaining that? And so something is maintaining this kind of thing, but please drill it into your head. Chronic pain is not the same as acute pain. And when a patient is saying, I hurt, but they've been worked up and there's no evidence of an acute pain contributant, and they do have a history of chronic pain, then the question should shift not entirely away from analgesia, but analgesia plus something else to help them with whatever they're going through in that moment. There are complex mechanisms propelling chronic pain that deserves a whole other separate talk. Today, we're going to get into a couple of those things that propel or maintain or prolong chronic pain. But suffice it to say, you're going to need to balance things out biopsychosocially. Another benefit to a psychiatrist getting involved, because again, many medical specialists will focus only on the biological components, but psychological features listed here, as well as social variables, can clearly contribute even more so sometimes than medical phenomena. This schematic is a little busy, but it's basically a visual reminder of what we're talking about. Those who go off into the pathway of chronic pain may be very different from those who don't, right? So you get 100 people with the same medical process or motor vehicle accident or surgical process, and some of them develop chronic pain and many others don't. And so there's something clearly different about their diathesis and risk factors. So there may be innate mechanisms, genetic loading, early experiences, trauma, things like that, certain thinking patterns, certain coping strategies or lack thereof, and certain comorbid psychiatric states. And then boom, you have this phenotype of complex chronic pain. So keep that in mind, of course. I think this perspective is very valuable at the bedside too, because I find myself talking to patients time and time again about their early trauma, adversity, early insults, and how that may have neurologically primed them for a complex chronic pain phenotype. That neurological priming, and I'm using those two words very specifically, can be very valuable to meet the patient where they are and help them understand that there's more to this than just their knee hurting or their back hurting. I'm going to again, sort of remind everyone to think about the pain experience. Put yourself in their shoes and ask yourself, is this person just hurting physically, or are there other psychic elements to what they're experiencing? Are they afraid? Are they angry? Are they having all sorts of other psychological dimensions to this? And of course, that's going to assist you in determining what's, the intervention at that point. And I'm of course keeping in mind the people that are very complex, very chronic, very refractory to most treatments already. So by the time we get called, it may be that we're looking at the third bullet point here, predominantly psychobehavioral or whatever term you want to use, in the sense that they're going to need something different, including pharmacologic changes, but also behavior modification, psychotherapeutic techniques, etc. I want to focus on one phenotype of pain experience that is very prevalent in the complex chronic pain, sort of disabling pain phenotype, and that is pain as experienced as a threat, or experienced with immense fear. This may not even be, by the way, very consciously accessible fear. Not to get too psychoanalytic, but what I mean is it could be pre-conscious, in the sense that the patient is saying, I hurt, I hurt, I hurt. And all it takes is a little bit of examination and exploration to realize I hurt and I'm afraid. And that's critical, again, for psychiatrists' role in this. That's a small but very important step that you don't see other providers take. It could be that pain is experienced as an actual threat to bodily integrity. Literally, you'll hear patients say, it feels like my body's breaking down. I'm going to die. My organs are going to shut down. My bones are breaking. This is very colorful language that, we may sometimes just say, oh, it's hyperbole, or even, think, oh, this is a somatic delusion. But frankly, if you really examine most of these patients, barring any, again, comorbid schizophrenia or anything like that, often they really are phenomenologically terrified. And that's important, again, as an indicator of a possible PTSD or fear-based kind of approach to pain. So pain psychology needs to be examined. And we're going to go over that briefly, a brief approach to it. This schematic on the right here is basically a reminder that thankfully most people are resilient enough, don't have other risk factors, and they sort of bounce back and recover nicely. But some people are caught in this vicious cycle based on their pain experience. That's the fork in the road, if you can see there. And if you have a negative, fearful, angry, scary pain experience, it's going to decorate how you're going to move along through the care after that. And you can see the other components of that cycle. We have to break that cycle, obviously, therapeutically. But before doing that, you have to identify the pain experience. So pain psychology, I'm not going to go too in-depth into this, but just to give people a few tidbits, we are psychiatrists at the end of the day, and hopefully we're still interested in psychology. And by the way, parenthetically, there is a whole field of pain psychology separate from pain psychiatry, if you will. And there are psychologists who specialize in this, and they're quite valuable in what they do. But I think as CL psychiatrists encountering patients like this, we might be the first ones to introduce the idea of pain psychology. And so you should have a bit of a lingo and identify some of the patterns that come up. And, we all know affect, behavior, cognitions, and of course, social and environmental things that affect our patients. But in pain psychology, you can kind of see correlates in this that have been researched and vetted, and there's even instruments to measure these. And I would classify them as such. Affect might be termed pain distress. Behavior might be termed pain avoidance, because obviously pain is not a pleasant thing. It's an ego, dystonic phenomenon. People really want to avoid it, but how they avoid it is critical for us psychiatrists. Cognitions involve particularly pain catastrophizing, worst case scenario, kind of thinking from CBT parlance. And then social, environmental variables include things like enabling stressors and incentives. Each of these topics can deserve a full talk on its own. And this is actually what I teach, fellows and things like that who rotate through our service. But suffice it to say, if you start to know a little bit about this world, then you can reach your patient and identify things that can bridge the gap to care. This ABC's mnemonic is mine. I just kind of made it up one day and use it to teach. But there's sort of some unpacking of what each of these means. I'm not going to go through it all. I will highlight under behavior, which is very relevant to us in CNL, that avoidance can take the shape of checking out pharmacologically, right? And that could be CNS suppressing drugs like opioids, benzos, illicits, cannabis, alcohol, whatever. It would be natural, actually, if you had, constant, unrelenting pain, to turn to something that would shut your brain off or your nervous system off. So keep that in mind, that can be a form of avoidance, but also form of avoidance might be not talking about the fear of pain, as in PTSD. A form of avoidance could be not moving your body because you're scared of the pain that moving causes, things of that sort. I see a number of people that become agoraphobic, because of their chronic pain. And so you can see the layers of psychiatric sequelae mounting. These are just a few reminders of things that you can do quickly to assess, affect. Believe it or not, in pain psychology, they also use the PHQ-9 and GAD-7. In pain behavior, there is a pain disability index that is very valuable that one could utilize to see just how impaired somebody is from their pain across 7 different domains, like family responsibilities, work, sexual behavior, things of that sort. It's very interesting to see what people sort of mark off as total disability and things like that. It's also an interesting screener, by the way, for those who might be malingering, because I often see people do, 10 out of 10 all over, but they're walking, they're laughing, they're actually doing okay. And, you wonder if maybe they have an addiction and they're trying to get, painkillers, or they're trying to get out of work or something like that. So this is an interesting scale that I just want to kind of sensitize you guys to. I'm happy to make these slides, by the way, available later if you want to review them on your own. Pain catastrophizing when it comes to cognition is very important. It's a strong predictive or poor prognostic marker for chronic pain patients. If they're catastrophizing actively, they're not going to do well. They're going to be circling the drain, if you will. So identifying this can be valuable, and some patients might be more amenable to this sort of scale than a prototypical stress or depression kind of scale. Finally, when it comes to social variables, I think it's very important to pick up on patterns that, signify ongoing disability, right? So this is obviously stressors, which we all do as psychiatrists, but particularly in not only chronic pain, but also addictive disorders, you want to be looking for enabling, right? So social contacts or environmental contacts like family and others who are, propagating this kind of, behavior, avoidance, etc. That's very critical. If you see that, it may be a very poor prognostic sign, and it may be time to, intervene at that level if you can. And then finally, incentives for staying ill are very important, as in with malingering, amplification of symptoms for secondary gain, etc. Avoiding work, ongoing lawsuits, things of that sort are very poor prognostic findings. In fact, there's evidence to show that if people are in lawsuits and they get things like spinal cord stimulators or go through pain rehab programs, they tend to do very poorly. And it's probably because either consciously or not so consciously, they want to fail to get even more rewards from their disability application or lawsuit. So keep that in mind. Just be curious about the patient. There's no great scale for measuring this. I think as CNL psychiatrists, we do this routinely, or should be, contextualizing people's behavior and understanding that, we want to be compassionate, but also a little skeptical about what they bring to the table and match objective findings with subjective complaints. There is one scale that I do suggest using as a bridge to another topic that I think is going to be very relevant for us in a minute, and that's the ACEs scale, Adverse Childhood Experiences Scale. Many chronic pain patients have not been asked about previous trauma, whether it's childhood adversity, physical, sexual, violent abuse, or neglect, emotional abuse, caregivers that were checked out, intoxicated, things of that sort. The ACEs scale, in my opinion, does a very good job of picking up on that. And it's been correlated, as you might know, with all sorts of poor health outcomes, not just in chronic pain, but in addictive disorders, in obesity, a variety of medical concerns too. And I think it serves as a decent bridge, actually, to open up dialogue about the role of trauma, PTSD, and then central sensitization, which is a very key. Sorry? Oh, I heard a voice, sorry. Central sensitization is a very key, term that we're going to be using in a minute to bridge to care. I want to just spend one moment on, and this is more so because I have this kind of interest in this, on psychodynamics of chronic pain. If you look at the literature, there's of course some evidence to suggest that CBT and chronic pain can be very helpful for your mild to moderate cases, but in stubborn, very complex trauma, severe cases with personality disorders or personality disorder traits, you might want to lean in on a dynamic formulation. I propose that, and I've actually given examples in this write-up here that I'm showing. I propose that because you can pick up on enactments and things that are coming up, transferential and countertransferential, that are coming up between the patient and providers, hostility, anger, resentment, passive aggressiveness, all these kinds of things that can manifest. And if you don't know to look for them, you could be blindsided and be very frustrated. It's part of the broader countertransference sort of management that we should be doing in CNL. But I think these kinds of, parallels in chronic pain are quite prevalent, particularly for those really animated, dramatic ones that get under our skin. And so I advise thinking dynamically about that If you want to ask questions about this later, that's fine. But, be curious about early, caregiver experiences and how they're manifesting currently. Let me get to something more practical, though, because this is all way too heady, right? It's all psychology and, the ABCs and psychodynamics. Now I want to pivot a little bit to get really practical with the patient in front of you, right? The patient is hurting. They're somatically preoccupied. They're complaining about the same pain they've been complaining about for years. Everyone's, throwing their hands up. They don't know what to do. My advice is that we look at the patient agenda and we sort of translate it. It's a little bit of a bait and switch, frankly, but it's not, scientifically incorrect. And I think it helps bridge us to care. I sort of call this agenda that the patient has a peripheralist agenda, meaning they're really focused on their peripheral body, right? Peripheral nervous system, their joints, their back, their foot, their belly, whatever's hurting, without a lot of consideration about central nervous system components to this. And so, if everyone, including other doctors, by the way, maintain that peripheralist agenda, the neurologist, the spine doc, the orthopedist, whatever, the gastroenterologist, if we really only stay in that realm, then we're really missing a big portion of the pain circuitry loop, right? And so I think it's important to get to the physiologic reality of this. There's almost a fantasy that it's all in the periphery. Actually, no, it's very complex, and there's a lot of reality physiologically in central nervous system processing, and reminding ourselves, as well as other physicians and the patient who may not even know, they don't have any medical training, that there are central nervous system components to pain processing, right? So as a very, brief reminder, remember that pain is transduced and picked up on with nociceptors in the periphery, and then transmitted to the spinal cord, and then up spinal thalamic tracts to the brain, and then it's perceived, and then there's even further downward projections. As you can see, this is fairly complex. There's a lot of steps in this process, and a lot can go wrong in that. So I think this integrative perspective of not only looking at the periphery, but also the central nervous system is critical for reaching your patient who is a chronic pain, disabled kind of mess, if you will. And this is perhaps the most important slide that I'm going to share today, is the idea of sort of neuro-validating them. Not a real word, it's my neologism. I'm prone to neologisms. But I think it's valuable to kind of validate the person's neurological state. I want to, for a moment, step back and, that Cleveland Clinic program that I was in, I want to mention something. It was housed within the quote unquote Neurological Institute. I was, like I am today, wearing a white coat and in an exam room. It wasn't in, a prototypical psych facility. There was all of this jargon, being utilized. It was all of this ritual that was very medicalized. This was far more effective at reaching patients that were, again, sort of in that peripheral kind of somatic kind of mode. And rather than saying, well, you should go to psychiatry because of your stress, anxiety, depression. I just want to put that out there because it can be very validating to their agenda, very destigmatizing, and it's still factual and accurate. People with chronic pain do have chronic neurologic disorders. And the way that they become chronic is through a process known as central sensitization, something that I think every CL psychiatrist should probably be familiar with. It involves abnormal and intense pain enhancement in the central nervous system, characterized by two phenotypes, hyperalgesia and allodynia. Hyperalgesia is where you feel more pain than you should based on the stimulus, or for longer periods of time. And allodynia is when you feel pain when you shouldn't, based on the stimulus, maybe something that normally should not cause pain. I think it's enormously important to have these ready to go when you meet a patient, because if they meet a psychiatrist who's talking about central sensitization and allodynia and hyperalgesia, suddenly it feels very different to them. They say, wait a second, more, again, like Jeff was talking about with the intensivists and all of that, more about this than just shrinking heads. And it's a bridge to maybe eventually shrinking heads if you have to, but initially you have to meet them where they are with their medical agenda. This is just a little more dorky information on what happens with central sensitization. I'm not going to belabor that. You can geek out on that on your own if you want. A couple of visuals that I like to share, not only with trainees, but sometimes with patients if they're sophisticated enough, is the idea of how neural pain signals work and sometimes don't work. In this case, we have normal sensation with the yellow stimuli activating action potentials and causing pain. And then you have non-noxious stimuli like the feather causing different sensations like touch. However, in central sensitization, for complex reasons that involve neurotransmitter changes, NMDA, receptor changes, et cetera, you have noxious stimuli activating hyperalgesia, and unfortunately, even things that shouldn't cause pain getting rewired. Notice this arrow here getting rewired up to cause pain. And that's an important reorganization that you should be aware of, and even patients sometimes should be aware of. This is, again, getting away from the periphery entirely and focusing on other neurologic changes. This is perhaps the busiest slide I have, but it's basically a good visual for you, not so much a patient, but also, again, for trainees and others to appreciate the different levels of interaction here. The periphery is on the bottom. The central sort of nervous system is in the top and middle there. You can see with this example of RA that you have a neuroinflammatory, component to it, very real peripheral contributant, and that needs addressed. However, over time, it causes changes in nerve pathways, not only in the periphery in terms of neuropathic pain, but also spinal cord and brain, regions. And then you have, from top down, the topmost box, you have cognitive forebrain kind of products that can worsen the experience, right? The pain experience. And that's where we really have an opportunity to intervene. This is my favorite simplified version of the central nervous system for teaching purposes with patients, and I'll explain why. You can see the periphery here simplified, and then the spinal cord and the brain. But my favorite part of this is this blue part here, this descending pain pathway. It's very important because this is actually our clinical target when it comes to meds, which we'll get to. If you're wondering when we'll get to meds, frankly, I think that's the easy part. I think setting the stage like this is the hard part. And so I'm spending a little more time on that. But anyway, when you appreciate that we have a descending pain pathway with your periaqueductal gray releasing endorphins and endogenous opioids, you have to ask yourself, is this patient's descending pain pathway strong, weak, online, offline? Is it suppressed? Is it something we need to bolster? That's where neuropharmacologically I'm thinking about helping this patient. And so what that might mean, and we'll get to this later, is lifting opioids, lifting benzos, introducing TCAs, introducing SNRIs and other treatments, which we'll get to. But please keep that arm in mind. I even tell patients about it because sometimes they're physically deconditioned, they don't do much activity or, God forbid, exercise, and I invite them to beef that part of their nervous system up because it does release endogenous painkillers and kephalins and all that stuff, and it makes them feel good. And I use that lingo that most people are aware of. You have adrenaline in your body, you have endorphins, and most people have heard of that. And so it remains medical and scientific, right? If you invite them to do more PT, for example, or recondition this pathway, all part of that neuro validation, if you will. As it becomes relevant for us psychiatrists, it's important to ask yourself, is this person's brain sensitized? Most of the times it is. If they have chronic pain lasting of years and they have psych comorbidities, early trauma, things of that sort, then yes, they have a sensitized brain of sorts, right? Putting aside the spinal cord for a second. And you want to ask yourself, is there a PTSD model that I mentioned earlier at play? It may not be PTSD about, a trauma that was perpetuated many years ago, but maybe that primed them, and then they have a medical insult, accident, injury, et cetera. And now they're really focused on that and avoidant, hypervigilant, all the things that you see with PTSD around the pain or the symptom. There are actually strong neurobiological correlates, by the way, in the CNS and in the brain between PTSD and chronic pain. That has been shown experimentally. There's a good resource there, a reference at the bottom of the slide if you're care to look at those neuroimaging studies. In an oversimplified kind of way here, just a reminder, some of our patients, not only in chronic pain, but in other parts of psychiatry, have weakened top-down regulation, cortical regulation of subcortical structures. This is a schematic of sort of PTSD oversimplified and how, your evolutionarily fast, primitive subcortical pathway might get activated by a dangerous situation or stimulus. And then after that, the rest is history, right? Without much top-down regulation. And so that's kind of blown out. Well, in pain disorders and chronic pain, you can see the same thing where pain is the actual stimulus that is causing these pain behaviors, physiologic effects, sympathetic nervous system outputs, things of that sort. So it's no wonder somebody would be looking as dramatic and as chaotic as they do if they have this kind of PTSD analog to them. Now let's get into management and treatment, right? The sort of logistics of this. I will say that before getting into actual interventions, everything that I just mentioned is part of the treatment. It's a paradigm shift. Not to get too philosophical, but you're really switching the sort of prism of care here for the patient, as opposed to going to 10 more orthopedists or whatever, or getting another 8 regional nerve blocks after the first 10 didn't work. We're looking at a different approach. Let's look at the central nervous system and how we manage that. And I think one emphasis might be on managing it, again, on a regular basis, daily if needed, rather than curing it. That can be a serious letdown for some people. Some people may not be ready for that kind of switch, but until they do that, they're not going to get much better. And so it's important to utilize whatever bedside strategies you have, psychotherapeutic training, rapport, etc. MI, motivational interviewing can be valuable in this sense to see if we can reach a patient. One MI tactic that I often use is the sort of pros and cons of, continuing on opioids, or the pros and cons of seeking, again, multiple specialists. And usually the patient comes to this conclusion that they're not much better off escalating their opioids or, doing these other things. And what we reveal instead is that they're terrified of not doing those things, terrified of withdrawal, for example, terrified of not knowing what to do with themselves if they don't have multiple medical doctors to see. So keep that in mind when you're trying to switch from cure to management. And of course, management may involve rehabilitation of sorts. This person you're seeing wasn't always like this, right? They weren't born in a crippled, chronic pain, opioid-ridden state. They became that. So how do we get them back to their premorbid, or as close as possible to their premorbid state? And that would be a rehabilitative process, medically, psychologically, and physically. There's a variety of things that are going to apply differently from one patient to another. Getting familiar with practice and time and pattern recognition with what each individual needs is very critical. Usually for the severe cases, you're going to have to do all three, though. If not, that stool will fall over. You're going to have to kind of use all legs of treatment, if you will. And so I advise thinking across all three domains. Now, pain psychopharmacology is another topic that I spend, many hours on with my fellows and other docs that I work with. Today, I'm going to be very brief about it, just because this is all a big, primer, if you will, and just a slice of my world. If you have questions, I'm happy to help later on. But the first thing to know, as I mentioned earlier, in CNL, we do a lot of pharmacologic creativity, right? Whether we're managing delirium, off-label medications, catatonia, a variety of syndromes. The same is here, believe it or not. There's very few things that are FDA approved for chronic pain. There are some for chronic neuropathic pain, like the gabapentinoids, but that's kind of it if you really look at the evidence base. So the norm is actually a lot of creativity, using adjuncts, using meds that are not really analgesics for chronic pain. It's an underdeveloped field, probably because, again, we've been focusing way too much on the periphery and not really including central nervous system, targets, and R&D and all of that in that space has really lagged. So I think this is where we shine, actually, as CL psychiatrists, because we're accustomed to doing this kind of experimentation. Not callous experimentation, but experimentation nonetheless. Then the hardest challenge, but I think really critical thing to consider, you may not be able to accomplish it, but to consider, is to remove CNS barriers like benzos, opioids, and marijuana. I can't tell you how many times I see this as a huge impediment to the patient getting better from anything. If you try to add, a TCA, a Cymbalta, whatever on top of this, it's unlikely to help. Again, the MI complex work here is educating patients on how these meds may be causing them more harm. Maybe they're causing opioid-induced hyperalgesia, which is interesting if you think about it. Paradoxically, the thing that they think is helping them with their pain is causing more pain. That kind of mental judo, if you will, can be very valuable. And I have seen some patients make the switch because of that recognition. Same thing with benzos, advising them that there are long-term risk factors to this, that it's not just addiction and, criminality and stuff that they don't really relate to, but actually that it's more so, dampening their descending pain pathway. Things of that sort, I think, are much more effective as levers for reaching the patient. Then there's a variety of meds. This is where it becomes easier using these meds once you've addressed, the previous two. Of course, if you cannot address the previous barriers, pharmacologic barriers, then maybe it is still a good idea to try to add a medication here and there. But in my experience, it also feels a little bit like a distraction and you're kicking the can down the road and only adding polypharmacy. So use your own personal kind of, compass, if you will, to determine if you just want to add more things to somebody or really work on what is absolutely needed. I'm going to review these very, very quickly, and then we can pause for some questions, hopefully. I mentioned this already, but when it comes to avoiding chronic opioid therapy or benzotherapy, you want to kind of use a sophisticated MI kind of approach, looking at what are their concerns, not your concern, not like, oh, I'm worried this person's going to get addicted, not, oh, I'm worried they're going to overdose. That actually rarely helps if you think about it. Most patients think that they're exceptional from addiction and death risk. And they actually feel stigmatized if you bring that up. I even say, I get ahead of that with my patients and say, I'm not concerned as much. I am, of course, concerned, but I'm not concerned as much about dependence, addiction, and death and overdose. What I am concerned about is you want your pain treated, but your meds are in the way. I cannot, and no one else can, help you with your pain management because of these opioids. And then explain why, right? And I get into opioid receptor upregulation and opioid-induced hyperalgesia and yada, yada. And that can sometimes, not always, really open the door for somebody being open to detox and taper. And I have separate talks and things like that on how to taper. There's far more to say about this topic. I've counseled, hospitalists, medical teams on how to do it. It's a whole other thing that I don't want to oversimplify, but I think it is very important to at least attempt this. And by the way, the inpatient medical setting is not a bad place to try it because of all the bells and whistles and monitoring that you can do, whereas, outpatient is harder. It's definitely harder. I'm going to skip through this very quickly about benzos, but just notice in bold, benzos, according to studies, predict opioid use better than pain does. So if you see somebody on chronic benzos, they're already at higher risk than the pain itself that they experience at ending up on opioids. That's fascinating to me in terms of weakening, again, their descending pain pathway and limiting their internal coping strategies or ability to tolerate pain. And then the reverse, patients on chronic opioid therapy had 12.5 times the odds of being prescribed long-term benzos as patients who did not have opioids. So you can see how they each kind of feed each other. And I think we all appreciate this with the sort of co-epidemic of benzos and opioids. As far as cannabis, don't get me started. I'm not a big fan. Obviously recreational and people who have low risk factors, that's fine. But a lot of the patients that we see, if you hadn't already appreciated, have a lot of risk factors like trauma, psych comorbidity, et cetera. And they're usually neurovegetative, amotivational, scared to move. I don't see cannabis as really a good solution for this. This is all taken out of an editorial that I put out. And the evidence base hasn't really borne out. There was a hot moment there where everyone was talking about CBD for pain, and there's still some chatter about it, but let's not kid ourselves. It's not very effective. So if you're interested in these kinds of bullet points as to why cannabis, particularly unregulated street cannabis, is not a good idea, you can review this on your own. Then there's central sensitization or chronic pain psychopharmacology. The image here is a fun reminder of what is a true anxiolytic, antidepressant, or analgesic, and what has shared properties from each in a Venn diagram form. I'm going to very quickly go over this. The temptation with looking at this is that everyone should just be on TCAs and SNRIs, right? Because it covers all bases. However, again, learn what is going on with your patient and their pain experience, because it may be much more about anxiety, trauma, something else than pain. And if that's the case, you might not use a TCA or an SNRI. You might use a mood stabilizer. You might use an SSRI, which I see myself doing a lot of, by the way. Here is the geeky scientific explanation why TCAs and SNRIs work for pain and SSRIs and other antidepressants don't. It's because of the shared norepinephrine and serotonergic reuptake inhibition. And basically, it's been shown through experimentation that analgesia can be antagonized by the use of antagonists at serotonin and norepinephrine, which is really interesting. SSRIs, by comparison, are largely ineffective for this. But if you really wanted to get some of that kind of neurobiological background, there's a reference there. And once again, notice this is the descending pain pathway that I was mentioning. This is our area of intervention, if you will. I wrote a review with some colleagues on using TCAs for not only pain, but other syndromes and sort of beyond depression, if you will. And this is just meant to be a reminder that you can review on your own as to, their side effects, their profiles, their dosing ranges. And this table has a variety of conditions that have either some modest or high level of evidence for using these agents in their dosing, their side effects, things like that, but also some side effect management stuff. I think a lot of CL psychiatrists, shy away from TCAs because of QTC prolongation, anticholinergic effects, et cetera, which are obviously to be monitored and relevant in particularly older populations. And in CL, we see a lot of older populations. But if you're seeing a younger or middle-aged individual with this, again, chronic disabling pain, and they haven't had a trial of TCAs, it may be worthwhile trying it. I often will use amitriptyline 50 milligrams. I'll jump to 50 in the inpatient setting because I can monitor, because I can get another EKG, et cetera. And oftentimes patients will thank me. It's like, wow, I finally slept, Now, moving forward, if that's going to actually bear out with pain control and other benefits is to be determined. But it at least gets past the hurdle and it builds rapport because you're being practical and helping them with something that they were suffering from. And FYI, parenthetically, the majority of patients with chronic pain do not sleep well. So if you can help them with that, you're doing something very beneficial to them. SNRIs, very quickly, I will say that a Cochrane review, and my clinical experience has borne this out as well, are not as effective, in my opinion, as TCAs and some other agents for chronic pain. They were, of course, heralded with huge promise because they're safer than TCAs and yet have some pain relieving properties, and they do. So mild and moderate cases might benefit, but I don't know about their anxiolytic properties. I don't really know if I'm getting, the best effects. And there's often this temptation to just jump to Cymbalta Effexor, for example, in your chronic pain patient. But I would resist that temptation. Don't oversimplify. Try to look at other treatments. And this is a slide dedicated to this because, it's kind of like duloxetine is everywhere, right? When you're in an academic tertiary care center, when you have a complex patient, maybe think a little more beyond that. I find it to be okay for depression, but really not the best for severe anxiety, uncontrolled PTSD, things like that, which once again can be a huge component of uncontrolled chronic pain picture. Instead, look at the psychiatric priority and maybe dip into mood stabilizers, atypicals, which we'll get to, and TCAs and other things. Even SSRIs, right? If you have a bread and butter kind of like panic disorder or PTSD. And this is what I'm getting at with SSRIs. I'm a big fan of pushing them fast and hard in somebody who's otherwise healthy and young to get past that initial fear of like side effects and this and that. Of course, you're going to have to use your tact and your awareness of the specific patient in front of you, but they can be actually very helpful in chronic pain when somebody has enormous anxiety noise at the same time. And as a reminder, you probably didn't need this slide because you're wondering, yeah, but they're here for pain. Well, up to 50% of chronic pain conditions could have anxiety and depression comorbidity per epidemiologic studies. So this is not, 10%, this is not 5%. About, 1 in 2 of your patients with chronic pain are going to have anxiety, depression that is a target for, an SSRI, something like that. Very quickly, the anti-epileptics, which we also classify as mood stabilizers, can be valuable. I'm not going to spend a lot of time on gabapentinoids because they're very popular and I think everyone knows about them. Carbamazepine, oxcarbamazepine, we've used less and less in mood stabilization, but they actually have a great role in certain neuropathic syndromes. They can be very valuable, and I would say don't shy away from trying them. Of course, monitor their side effects, hyponatremia, sedation, etc. I'm going fast because I suspect you're somewhat familiar with these agents. Topiramate has a role in headache management and in other neuropathic pain, as well as lamotrigine, actually, believe it or not, in chronic neuropathic pain, post-stroke, central pain, things like that, neuropathies. So think about these agents that should be familiar to you as a psychiatrist. Depakote, which I love, can be very valuable in a sort of acute migraine state, acute pain state, sort of calm everyone down just for a moment, use it as a bridge to then introduce some other agents. As you know, we use it a lot in the inpatient CL side too. And then lithium, believe it or not, has a role in a very specific pain problem, and that's cluster headaches. It's interesting. So you may not see that very often, but just keep that in the back of your head in case you encounter it. A word on antipsychotics, which are my favorite. I did a review on the role of atypical antipsychotics in pain management because I started to see some patients respond to the use of adjuncts, particularly very anxious, very destabilized patients. And I found that there was some evidence, but really not a lot of rigorous evidence. The one that stood out actually was olanzapine, and olanzapine, primarily in central sensitization syndromes like headache, migraine, fibromyalgia, etc. Just now on CL, one of the reasons I can't be there in person, I have a patient with pain all over, literally the all over kind of complaint. And we started olanzapine 5 milligrams at night, no other, therapeutics. And she's, calmed down, she's eating, she's sleeping, she's so thankful. And she's even considering going to psychiatry on a voluntary basis, inpatient psychiatry. Whereas before that, she was all about pain management and opioids and Xanax and whatever. And so I think there's something to be said about this, even if it's not long-term. Quetiapine also has a small evidence base that you can utilize. The article that I have here has some, monitoring guidelines like we use in schizophrenia management, things like that. But I would use lower doses here than I would in bipolar or schizophrenia anyway. This is also from the article, which suggests a workflow that you can review on your own if you'd like on how to assess your patient with chronic pain, history, physical exam features, different instruments if you might want to use them, and then differentiate to see if there's a strong central sensitization component, which is likely the case if you're getting called, and then look at the various treatments in order, eventually consider antipsychotics as adjuncts if it fits, and then monitor accordingly. Final, I'm almost done here. I know that we're wrapping up here with time. Final class, actually there's two classes. This is sympathetic modulators. That's what I call them at least, which is alpha and beta acting agents. They can be helpful actually in certain, not only PTSD-ridden states, but also in certain pain conditions like complex regional pain syndrome or reflex sympathetic dystrophy, which has literally a sympathetic component to it. Using things like propranolol, clonidine, prazosin can be valuable because of that sort of heightened sympathetic nervous system component. And the last class that I want to sort of bring up is not so much an analgesic, but something that is growing in popularity, of course, is Suboxone. It is being used for opioid use disorder. However, many patients are reporting that it helps their quote unquote their pain. I don't know if that's placebo effect. I don't know if that's direct pharmacologic effects. I think we need more studies to suggest that, or maybe it's just tamping down on withdrawal, and withdrawal can be painful. But keep it in mind, sometimes I've transitioned somebody from opioids to Suboxone with the prism saying it could help your pain because, again, they're very pain focused. And of course, I've recognized an opioid use disorder as well and transitioned them to that. Again, whether there's direct pain relieving properties or not is TBD. So I've said a lot. I'm sorry I went so fast. I just wanted to fit it in on time. But in conclusion, we're not looking at chronic pain as psychiatrists. We shouldn't. Acute pain as psychiatrists. We should look only at, in my opinion, chronic pain and consider central nervous system targets. Consider the actual pain experience. Consider the pathophysiology. Is there central sensitization? Is there some PTSD correlate? What are the pain psychological kind of factors at play? And explore, any psychiatric treatment priorities, sort of bait and switch a little bit with your pharmacology, and be creative and confident with that. If the patient, detects that you're not so sure, they're not going to really follow your lead. Pair your interventions with, of course, other rehabilitative efforts, including ICPRP. ICPRP stands for Interdisciplinary Chronic Pain Rehabilitation Programs. That's a mouthful, but that's that program that I had at the Cleveland Clinic. If you identify one like that and the patient's open to it, why not refer them? And then the most important thing, again, as a bridge, as a theme throughout this, is neurovalidating the patient, right? Making it known to them that this is medical, it's neurological. There are parts of your brain, including the descending pain pathway, that need attention, not to mention amygdala, fight flight system, blah, 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 and really validate them that way. If you do that, you've won half the battle, in my opinion and my experience. So thank you for your attention, and I'm happy to take any questions. Or not if we ran out of time. I understand if we have to jump to another speaker.
Hi, Dr. Jimenez. Thank you so much for this. You mentioned the psychodynamics of pain. So both Freud and Jung, they kind of like talk about the psychical inertia, where this patient goes through this repetition compulsions, where the anxiety or the neurosis are tightly held onto. Do you feel chronic pain also kind of had that? Have that kind of like phenomenological aspect to it, like it becomes so very much an identity part of the patient. It's very hard to take it away from the patient right away. So we have to kind of work in that manner. It's all
Absolutely.
medical.
Yeah. No, absolutely. Thank you for bringing that up. I think there are two parts of my presentation that suggest that stuckness, if you will, that inertia. One is that circle where they're in that vicious cycle and they're really not proceeding, towards recovery. And there's this repetition compulsion, if you want to call it that, towards curing or relieving pain. And then the other image is the sort of triangles that were paired that's more directly about psychodynamics. In my article, if you're interested in unpacking the sort of psychodynamics of chronic pain, I reference Freud and a variety of other thinkers and authors about the centrality of trauma and the corresponding mastery repetition compulsion around that trauma. And so things keep going in this vicious cycle, and that inertia that you describe is very prevalent. What I try to do actually is jolt people out of that inertia and remind them that what they're doing is not working, that they've lost so much, that their world has become very small, that things that they valued or the person that they used to be is no longer there. And sometimes that you can see this sort of affective flooding that happens with that. And it could be the beginning of a change, towards a different way to approach their chronic pain. But I think you're right in identifying that kind of stuckness, if you will, or inertia.
Any other questions?
Happy to share my slides with folks. And if you ever have, any questions, feel free to reach out to me. I appreciate the time, and I'm sorry I couldn't be there. I have all sorts of locura later this afternoon. Locura is, Latinx for craziness. So thank you for your time, and appreciate it.
Okay, round two. I'm just picking mine out. This is mine. Okay. Number 48. All right, Dr. Winnell. Sorry? No, they're different. Yeah, feel free to pick. Yeah, they all have the comic and then the novel or book varies. Yeah, that works. 13. This works. All right, Dr. Tabaja.
Forward, yeah. Left one is to go back, and the top button is a laser pointer. It's a laser pointer. All right, so I'll move this. Yeah, you should be all set.
7. No one with 7. Okay, we'll do another round. Wait, it might be me. Either way. Oh, okay.
That's fine.
Okay. Are you sure?
Yeah. I don't need to.
25. All right. And then I think we'll do 3 more at the end. Yeah, that sounds good. Yeah. Thank you. Appreciate it.
Okay, everyone, welcome back. Okay, so I am now very excited to introduce a fellow SLP board member, Dr. Shruti Mutalik, a transplant and consultation liaison psychiatrist at Mount Sinai Hospital. She currently works with organ donors and recipients and also serves as an assistant professor and educator at the Icahn School of Medicine. Her clinical and scholarly interests include organ donors, altruism and motivations for organ donation, military psychiatry, equity, anti-racism and disparities, psychotherapy, and psycho-oncology. She completed her consultation liaison psychiatry fellowship training at the Memorial Sloan Kettering Cancer Center, where she also served as chief fellow, and her geriatric psychiatry fellowship at the Zucker Hillside Hospital, Northwell Health. Following this, she served as an active duty Army psychiatrist at Walter Reed National Military Medical Center in Bethesda, Maryland. During this time, she also completed a 9-month deployment to Kuwait with a brief forward deployment to Jordan. She looks back on her time in the Army as among the most memorable experiences in her life and is thrilled to be able to share her journey with you today.
Hi, everyone. Thank you so much, Ada, for that very wonderful and generous introduction. I'm absolutely honored, thrilled, and delighted to be here at this evocatively named Spring Symposium of the SLP. Thank you so much. And I am so grateful for this platform to be able to tell the story of my experience as a military physician, more specifically as a military psychiatrist, and most specifically as a CL psychiatrist. Since I'm going to be talking about the Army and the DoD, it is customary and true that I'm going to be expressing my own views. They don't represent the views of the Department of Defense, Walter Reed National Military Medical Center, the Army, Medical Command, US government. It's all me. The presentation, since this is 2023, I thought I'd say that I did not use any AI platform or technology, no ChatGPT, no Google Bard. I'm also going to be speaking my own truth from my own experiences. So, of course, a lot of this is like verifiable, factual, Googleable information. And of course, as appropriate, I've tried to reference the evidence base. But a lot of this is really sort of field notes, my own like first person experience. And also because I'm going to be talking about my service in the military or my time then, I think that I wanted to express that there are so many service members that have over the years, presently, and in the future, either have or they're going to, serve much longer periods of time, like 20 years, 30 years. There are people, of course, who have sacrificed life, limb, vision. And so I think that I stand in a very humble, sort of minuscule place in comparison with the magnitude of so many of these sacrifices. So I just wanted to sort of express that humility. There is an inscription at Walter Reed that says, "Some give all give some," that I thought sums some of this up. So when I was in the military, as we learn about a little more today, there were lots of acronyms that I acquired, and one of them was BLUF. Does anybody know what BLUF means? So it's bottom line up front. Always say like lead with the lead, say the most important thing first. So I think if I had to summarize this, I would say that my active duty time, which was 4 years from 2015 to 2019, was amazing, very memorable. Certainly there were challenges and ups and downs, but it was absolutely mind-blowing. And so I'm going to share some of that here. I'm also going to talk about how principles of CL are applicable in military psychiatry. And also when I was at Walter Reed, what it was like, the CL service, what was the kind of work that was done. And although I'm going to do most of the talking, I think that this is really about you. So hopefully there'll be some takeaways and lessons that you might walk away with. All right. So branches of the military. So there's the Army, Navy, Air Force, Marines, Coast Guard, National Guard, Space Force. All right. Quick quiz. Which is the youngest of these branches? Exactly. So I think that's an easy one, right? So basically, it was the branch that was launched, I believe, in December 2019 after 73 years, and it falls under the broad purview of the Air Force. There are also non-uniformed service or uniform non-armed services like the Public Health Service. All right, what is the mission of the military? I'm sorry? Okay, yeah, I think that's very concise and succinct. Protect and serve, defense. These are some words that come to mind. Lieutenant Colonel Rohul Amin, who's a wonderful military physician officer, had actually given a talk to our fellows. And in that, he said this thing, that the mission of the military is to further the political will of the United States. And I thought that was actually a very helpful way of summarizing it. So the military is actually one of the instruments of national power in the strategic framework. I'm not a strategist, but there is this DIME framework, which is a very popular framework since many years to conceptualize what are the ways in which a nation state can exert power and influence on the global arena. There's diplomacy, negotiations, talks, etc., strategic removal of diplomats. There's information, media, social media, press releases, all that, the internet. There's economic ways like sanctions, etc. And then there is, of course, the military. All right. So from that global perspective to the personal perspective. So when did I serve? Like I said, August 2015 to the end of November 2019 was the time when I was active duty. But I also served through a program called MAVNI, or Military Accession Direct to National Interests. And this program basically required that I be enlisted for about a year and a half until my commissioning orders came through. This is pretty unusual. And so during that time, I used to be in the reserves. And in the reserves, basically, you only one weekend of the month, you basically do this thing called the battle assembly or the drills where you go to a military base. I went to Fort Hamilton to do this. And when you're active duty, you're basically in uniform every day. So it's your full-time job. In the reserves, people often have another job, and then they go to these battle assemblies once a month. And also, there's another thing called the AGR, or Active Guard Reserve, which is when you're active duty in a reserve unit. So, like I said, Fort Hamilton was where I did the initial reserve part. And then most of my military service was actually at Walter Reed National Military Medical Center in Bethesda, Maryland. But there was also an overseas deployment, which was from August 2016 to May 2017. And this was in Kuwait. And there was a brief 2-week-long stint at Jordan, and I'll talk about this a little later. Also, is anyone familiar with the acronym? There'll be a little bit more about acronyms. TDY. So it basically means temporary duty. So when you're in the Army, you can be sent to temporary duty, as backfill or coverage or whenever there's a need. And so I did 2 months of that at Fort Leonard Wood, Missouri. So what did I do in the Army? So I was a psychiatrist. I am a CL trained psychiatrist, and that is something that I bring to everything that I do. But I was not specifically recruited as a CL psychiatrist. I was recruited as a psychiatrist, and the AOC, or the acronym for that job, is 60 Whiskey. A little bit more about that later. I served as I'll clarify. I see some expressions. So I was the service chief of the Psychiatric Consultation Liaison Service, and one thing I will say is that even though I served a lot of active duty service members, there are other beneficiaries of the Department of Defense. So there are retirees, there are veterans, there are dependents of the service members. Also, there are many, many different kinds of experiences that you can have as a military physician. I was at Walter Reed, which happens to be, flagship hospital, and it's on the same campus of the Military Medical School, USIS, and there was a residency program. So there was a lot of that, certainly, which is not necessarily the experience at every Army base. Also, before I forget, so a lot of people ask me, did you work at the VA? So the military health system is not the VA. Both of them are two excellent health systems that speak to each other through the Joint Legacy Viewer, but they are different health systems. So no, I did not work at the VA. All right. So when I joined the Army as a military physician, it was like entering a parallel universe, like entering a different world with a different culture, different norms, different customs, courtesies, etc. So you do practice as a physician in the Army, but you also have this other hat that you are an Army officer. And so all the rules of conduct that are applicable to all Army officers are applicable to you as well. So this was actually really mind-blowing for me. As an example, the military has its own justice system called the UCMJ, or the Uniform Code of Military Justice. And an example of some of the things that were very mind-blowing to me were, for instance, in the civilian world, there's not really sort of legislation or rules about who you can be friends with, who you can have coffee with. Whereas in the military, there is something called fraternization. So officers and enlisted personnel cannot really be friends. And if you are friends, you could be investigated, and that could lead to cutting of pay. You can lose your rank potentially. I mean, you don't always, but that can happen. Also, there is such a thing called inappropriate relationships. So you can't really, be involved romantically with persons in your chain of command. And if you are married, you can't really have, if you have a relationship outside of that marriage, those things are actually punishable. So adultery can actually cause you to go to jail. So these were things that, I had never imagined, that such personal things can actually be regulated, legislated, and punished within a system, but it does happen in the military. Also, you certainly have to be in uniform. You have to salute people that are a higher rank than you. People that are a lower rank than you will salute you, and you have to return the salute. Also, things like travel, right? So for instance, you can't really, even if it's not going to cost you any vacation time, you can't really sort of go to another country for a weekend and come back and show up to work, because beyond a 250-mile radius, you actually have to apply for a pass, which has to be approved. And international travel is kind of complicated. There are lots of area clearances, trainings, etc. So this was really sort of all new to me. There's also this, I've mentioned 60 Whiskey. That's the International Radio Telephony Spelling Alphabet, or the NATO alphabet. So I think a few years ago, many of you may have heard of the movie Whiskey Tango Foxtrot, and that may not have made sense to you, but basically that is that alphabet. So if I had to spell SLP in that alphabet, it would be Sierra Lima Papa. So this is like a communication code that's used. A lot of people ask me this question, weren't you following orders all the time? So that's an interesting question, because certainly there are situations within the military, or certain, like on the battlefield, etc., high acuity situations where a person who is in your chain of command may basically say, you need to do this, and there may not be the time or the place to question that. And unless it's immoral or unethical, you kind of do it. But two things. Military medicine is a little bit different. That doesn't really apply. So, for instance, your attending can't really order you to give benzos to a delirious person or something. That's really not the culture or the way it works. So that's important. Plus, I would say that on the officer side, there is certainly a lot of ways of asking for what you need, or saying that, yes, sir, I'm happy to do that, but to do that, I need XYZ. So it's not as straightforward as you're being coerced all the time. All right. So the army is not a monolith. So people in the army have different jobs. There are entomologists, engineers, artillery officers, signal officers, infantry people. There are all kinds of jobs in the army. And this is something that people may not know, because, you may look at the army as, okay, everybody is a soldier, but there are different jobs, and all those different jobs have different subcultures in terms of investment in, let's say, physical fitness. For instance, military medicine, the focus on physical fitness is not that much. A lot of, you just have to pass your PT test. Whereas if you're special forces or a paratrooper or infantryman, their baseline is like a perfect score on the PT test. So different subcultures are different. Also, different people have different levels of investment in a military career. And this is something that we see even clinically with our patients. For instance, there may be some people who absolutely want to retire, do 20 years, 30 years. Their military identity is super important to them. And those people may not, express symptoms. Whereas there may be someone who, a private, for instance, or a specialist who got in and very quickly realized that, oh, this is not really for me. And so may not be as invested in like passing the PT test or in not reporting symptoms, etc. Also, on the officer side, so there are these two tracks, right? There's the enlisted track and the officer track. The officers, their occupational specialties are called AOC, or area of concentration, and the enlisted, it's called MOS, or military occupational specialty. So yeah, just wanted to give a little bit of a visual of all the insignia. This starts with private first class. Often these are like 17-year-olds who basically, join the army, do basic training. And then, not everybody stays in, but if you do stay in, then, you could become the sergeant major of the army. I mean, that's the highest rank on the enlisted side. Then there's the officer track, and these are different tracks. So technically, yes, one way of looking at it is that the enlisted side is the executive side and the officer side is the legislative side. That's one broad metaphor that I've heard used. And yes, officers are higher ranking than enlisted, but I will say that a lot of senior enlisted NCOs, etc., have a lot of wisdom and experience, and often know very much more than somebody who is just commissioned as an officer. So yes, so the lowest officer rank, there's a lot of excitement on Zoom. So the lowest officer rank is second lieutenant, and the highest, of course, is general. This is warrant officer, another track as well. So I thought this might be a little bit of fun. Certainly I've put a few of the ranks on the enlisted side, on the officer side, PFC, private first class. I talked a little bit about this. Have people heard of this term DD 214? I think if you work in the VA, you probably. So I've put the answer here, but military service record. So at the end of your service, you're issued this, like, where did you serve, etc., how many years, what deployments, what awards, all that. Do people know what Roger that means? Or have some suspicion? Yeah, it's a way of saying understood. I hear you acknowledge that. Yeah, copy that is another thing that's used quite often. Like you tell somebody something and they'll say, Roger that. Yeah. DFAC. Do people know what DFAC stands for? Yes, exactly. So, of course, Dr. Chin knows everything. So it's dining facility. It stands for dining facility. So you often say, oh, I'm going to do chow in the DFAC. Like those are common expressions that are used. PX, do people know? post-exchange. It's where you get, all your supplies, including alcohol, the base. IED. So this actually is, it's kind of military, but it's also used in very common parlance in the newspapers. Do people know what the I in IED stands for? Yes, exactly. So it's improvised. It's something that people may not at the top of their heads know, but yes, it's improvised explosive device. And then there's also informal lingo, like, when you're asked to do some task, people often say, sure, too easy. So that's a common thing. Or, another way of saying, I'm hearing this, or I've been following this is tracking. Yeah, I'm tracking. All right. So very quickly, just a few other things. Yes, even as a doctor, I had to be in uniform every day. And I saw my patients in uniform, and it's the Army camouflage uniform or the combat uniform for ceremonies. So for instance, if this was a military setting, I'd be wearing my service uniform. And then, of course, while doing PT, you have the PT uniform. And there are rules and regulations around that too. So for instance, when you go outside, you have to wear your cap or your cover. And I've put in here, there was a case, and I'm sure this has happened more than the one case I saw, but, where a soldier actually started developing cognitive impairment. And it's interesting how, like, one of the first signs of that was that he stopped saluting. And if you think about it, like, there's a lot of executive function, right? Like all those insignia, being able to like remember what it means, calculating that this is a higher rank than you. So that means I have to salute. Oh, this is a lower rank. So that means I have to return the salute. So that was like one of the first signs of cognitive impairment actually in this soldier. Also, when you're talking to an officer who is higher ranking than you say sir or ma'am. So the custom is that in a regular conversation, you will just say, yeah, you did. Yes, ma'am, at some point during the conversation. All right. So I've talked a little bit about the regulations. There are uniform regulations, hair regulations. You have to, women have to tie up their hair in a bun. Of course, these regulations also sometimes evolve over time. I think what's relevant clinically is that military psychiatry or military medicine has a very strong occupational dimension, right? So you are taking care of the patient, but you are also responsible as a consultant to command, or you're also responsible to provide the army with a ready and steadily deployable force. And so there are medical standards for enlistment, medical standards for retention, medical standards for deployment, and these also include psychiatric conditions. So as an example, and some of them may overlap and some of them may differ. So an example would be, something like schizophrenia is you're not eligible for military service, for enlistment. And if you are in, and develop schizophrenia, it's very, very likely that you would be medically retired. But there are some other conditions that are a little more nuanced, like ADHD actually would make you ineligible for enlistment. But there's so many people who are diagnosed with ADHD while they're in the service, and you're not going to be medically retired for ADHD generally. So that's an example. Physical activity. So yes, there are certain standards that everybody has to meet of body composition, height, weight, and physical fitness. And when I was so I got out in December or November 2019. And back then there was something called the PT test, which had existed for years and years and years. And that was basically you have to do, a 2-mile run, push-ups and sit-ups in a certain amount of time. But now this has moved towards something called the ACFT, which is more of a CrossFit inspired kind of thing. It's supposed to be harder, but I can't speak to that directly. Also, weapons, just wanted to say that, again, there are so many different jobs. As a physician, guns or weapons don't come into play for you personally in a hospital setting. But when I deployed, yes, I did have an M9 revolver that I took with me, but it was put in the armory as soon as I got there. I also wanted to say that cleaning guns, you may not realize this, and I certainly didn't know, that cleaning weapons is actually a very laborious and cumbersome task. Like sometimes a whole morning or a whole day used to be like weapons cleaning. And I have this little picture here. Do people know what this is? I mean, you know the reference, but do you know what that thing is? Yeah, so it's interesting because when you Google it, it says like gun barrel sequence. But somehow in my mind, I hadn't realized this until I was in the army when I was cleaning my weapon with a brush. And then the sergeant said, oh, yeah, you have to clean it. And then when you look in, you see the James Bond thing. And then that's when I realized, oh, this is the barrel of a gun. And it looks exactly like this. I actually thought it was like a metaphor for a whirlwind or something. So anyway, this is what, you have to assemble and disassemble. And this is only during weapons training that was pre-deployment or during my officer training. It was not part of my daily life. Okay, segue into some of the CL stuff. So just wanted to give a picture of my beloved Walter Reed National Military Medical Center. It's a huge campus. Yeah, this is in the lobby. All right, so CL in the military. So some of the CL in the military. So first of all, I do want to say, just like I said, the Army is not a monolith. There are many different Army bases, right? So some of the Army bases will not have a dedicated CL service. They'll have somebody who's, covering outpatient, doing inpatient, who also does a few consults. But the CL service at Walter Reed was pretty robust, and they had connections to like the pain clinic, the GI clinic. Also, they do a lot of interventional psychiatry. So it's one of the few CL services in the country that actually does ECT. And now after I left, they've branched out into Spravato, esketamine, and TMS as well. But one of the unique things was the proactive consultation liaison model. So Dr. Hal Wayne, who was really like a pioneering doctor in the military that was the chief of the director of the CL service, he started this sort of preventative medical psychiatry or proactive wounded warrior consults. So the idea behind this is that during Operation Iraqi Freedom and Operation Enduring Freedom, there were lots of soldiers who were evacuated from a deployed setting that in the Army is called theater. The theater of war is the reference. So lots of them were evacuated, and you would imagine that a lot of them had a lot of combat injuries or were very traumatized, had pain, had a lot of psychological symptoms, and yet they did not, for the most part, you didn't get a lot of like reactive by request consults. And the reason is because in the Army, there's often sort of an internal as well as external, stigma, resistance to seeking help. Internally, it could be because of the sense of, stoicism, not wanting to appear weak. And also, actually, there are certain specialties, and historically, even within it, people perceive, maybe mistakenly, and it's changing, that it can be career ending. There are certainly like aviators, for instance, could be grounded if they speak to a psychiatrist. And so because of this, there's a lot of fear. And so what he wanted to destigmatize and humanize the face of CL and psychiatry. And so basically everybody who was evacuated from theater was seen by the CL service and was screened. And the whole focus was the therapeutic alliance. And often, there were longstanding relationships that were built over time with a lot of these service members. Also, and now I'm sort of summarizing stuff that has been done over many, many years, there were support groups for families of service members. There have been support groups also for doctors who were involved in some very traumatic work in theater, like identifying remains, etc. After I left, of course, during COVID, there were support groups for providers. Also, one of the very pioneering things that Dr. Wayne did was after September 11, during the Pentagon, after the Pentagon attacks, there were some victims that were hospitalized in civilian hospitals in the area. And basically, they very quickly mobilized, Walter Reed CL Service very quickly mobilized a team of a social worker, a psychologist, a psychiatrist that would keep rotating and would go to these hospitals, with the permission of the hospital leadership, of course, and actually do like a therapeutic debrief, just introduce themselves, build an alliance, not the traumatic debrief that's now pretty controversial, but really sort of supporting healthy defenses, following the lead of the patient and giving them the opportunity to talk about their trauma if they wanted to. And actually, in the paper that they published, they found that 6 months after the Pentagon attacks, the rates of the PTSD in that population were extremely low. So Another very fascinating thing or very sort of pioneering area is osseointegration. Have people heard of this? Osseointegration. So in the Department of Defense, the osseointegration program was initiated in 2015. And basically the idea was that traditionally, historically, when people have trauma and need an amputation, they have sockets and the socket-based prosthesis. But for a lot of people, this can be very painful or can be associated with, difficulty because of perspiration, ulceration, etc. And so osseointegration is basically an implant. I mean, this field is actually called implantology. So it's a metal implant, typically titanium, that's directly connected to the bone and that exits from the skin. And then the prosthesis is mounted around that. And they've done this for transhumeral and transfemoral amputations. So how does CL come into that? So just to give you a little bit of a visual of the integration of the metal implant into the bone. So actually the CL service there has been involved in a lot of, just like we have psychosocial evaluations for transplant, using some of the same principles, basically trying to identify strengths, vulnerabilities, expectation management, identifying, of course, depression, anxiety, treatable psychiatric conditions, initiate the development of the therapeutic alliance to set up these candidates for success, assessing their distress tolerance. And actually, in the outcome studies, the people who receive this kind of psychological counseling have actually done better than those who did not. Another very fascinating area is elective amputation. So this is, I will just briefly say that in training or in combat, people often suffer injuries. And sometimes what happens is that, people undergo limb salvage operations, but we used to see sometimes patients who used to say, okay, I've had 20 limb salvage operations and I still struggle with a lot of pain. I see people with prosthesis running around the track and I have pain only after walking like a block. So no, for functional reasons and for pain reasons, but basically to restore my functionality, can we consider an amputation? And so obviously this can raise for psychiatrists a lot of alarm bells, right? Oh, wait, you want an amputation? So part of that assessment was really sort of to evaluate the motivation, to rule out sort of absolute contraindications like apotemnophilia, which is called, amputee identity disorder or body integrity identity disorder, people who want to be amputees, but also sort of understanding, what was the expectation management, etc. Also, there was, I will reference this study, the METAL study, which is military extremity trauma, amputation, limb salvage, which was a retrospective cohort study that compared amputation and limb salvage. And, they looked for depression, PTSD, as well as used this functional assessment measure. And what they found was that amputation actually had better scores on many of the musculoskeletal function domains. There was a lower likelihood of PTSD, higher likelihood of engaging in vigorous sports, which are very important to a lot of service members. I will say, I know that this looks, very, very mind-blowing, and it is interesting, but I will say that, the caveat is that this is not directly applicable. It is applicable. Some principles are applicable, but it's not like this is directly applicable to that population in the sense that this was comparing limb salvage at the get-go with amputation at the get-go. It wasn't like people who had a limb salvage failed it and then got amputation. So that's an important thing to remember. But it was definitely, when I entered the military, I certainly had some, conceptions or misconceptions or biases about what amputation meant. And yes, it is traumatic and there's grief, etc., that goes with it. But it was just interesting to me that actually functionally people can do better with amputation than with retaining the limb. Also, another very interesting area, I don't want to spend too much time on it. And I think Dr. Jimenez talked to us about neurovalidation and pain and all that. So there is actually this very interesting, intriguing area psychologically, which is amputation for complex regional pain syndrome, which is a chronic pain syndrome sufferers. And actually, so the service at Walter Reed is involved in some of those psychosocial evaluations as well. And again, this sounds very surprising to a lot, or shocking, right, to a lot of people, that, oh, you're amputating a limb that's not gangrenous, that's not fractured because of pain. But actually, a systematic review of some of the case reports and case series of this kind of amputation in treatment refractory complex regional pain syndrome actually showed that 66% experienced an improvement in quality of life. They were able to use a prosthesis. Some didn't do so well, but less than 1/3. And of course, there was some recurrence or a significant recurrence of phantom limb pain, as you would expect. But at the same time, people did generally say that they felt better after the amputation. So this is certainly a very interesting area. A big area within military CL psychiatry is somatic symptoms. So what I'll say about this, there are many layers to this, right? So one layer is that people who deploy, people who are in combat or through training, often develop a lot of physical symptoms, right? Chronic pain, tinnitus, traumatic brain injuries, etc. But there is a relationship between somatic symptoms and PTSD. So there have been studies both in the military population and in the civilian population that have shown a higher percentage of somatic symptoms in those with probable or subsyndromal PTSD or after a trauma. And so, certainly there is a correlation, whether it's through physiological reactivation, whether it's through the mechanism of dissociation, the link being dissociation. There is some overlap between PTSD and somatic symptoms as an expression of distress. Also, there are many reasons, consciously or unconsciously, sometimes for people to, take a knee or to take a little bit of a timeout from their units. It's important to mention that PTSD is not always from combat, which is sort of a misconception or a certain idea or expectation that people can have. It can be from hazing, bullying, toxic leadership, military, sexual trauma. Also, going back to sort of the investment in the military career. So there are so many layers of, primary, secondary gain that are important to acknowledge, while also acknowledging that people are really suffering. So when people are approaching retirement, while they are invested in their military career, they may not even acknowledge their symptoms or their suffering to themselves, let alone express them to others. But as they're nearing retirement, there's certainly an incentive to report the symptoms. It certainly helps you retire with better benefits or with the appropriate benefits for you and the correct disability rating, etc. So there are these incentives at play to not report while you're in and to report as you're getting out. So I think that this is a layer that's important to remember. Psychological correlates of different wars. So what I wanted to say about this is that certainly, things like PTSD, combat stress, shell shock, as it used to be called, have been talked about for eons and eons, but sort of the psychological sense of meaning, the morale of different wars is different. So when you work with a veteran who may have deployed or served in a certain war, it can be helpful to understand that sort of larger global political context. So for instance, in World War II, certainly there were many people who were killed in action. There were people who were very traumatized and had injuries. But at the same time, it had a clear beginning. The war had a clear beginning and a clear end, and there was a sense of victory. As opposed to that, the Iraq War, had a beginning, but it doesn't have a clear end. And the whole ethos of it, or the whole sense of it, is multiple deployments. And then, for instance, when there was a withdrawal from Afghanistan, a lot of veterans who served there, had very mixed feelings of, anger, resentment, a sense of what was the meaning of my service. So it's important to remember all these things. Also, occupational exposure. So I think that this can also be war related. And it's interesting because we're talking about like functional overlay and somatization. And of course, we have to sort of keep that in mind. But we also have to remember that there are certain things that we may not learn about until much, much later, right? So for instance, Agent Orange, it was this herbicide that was used during Vietnam. And even though we knew it was associated with things like diabetes, amyloidosis, etc., it's only in more recent years that we have learned that it's associated almost people who were exposed are almost 2 times as likely to suffer from dementia or major neurocognitive disorder. So that's an example. Gulf War syndrome, TBIs are considered the signature wound of the Iraq War. Burn pits and burn pit exposures, we're only now learning about or trying to figure out. There's a lot of research going on the relationship. One very fascinating thing. So there's a gap in the literature. And if you were to serve in, if you were to work in the military health system, these are some areas that are mysteries, mysterious things that you could sort of investigate. So have people heard of Havana syndrome? Yeah. So if you haven't heard about it, I would just say Google it. You're probably going to go down a very fascinating rabbit hole. So basically, very quickly, what it is that back in 2016, American diplomats who were in Cuba they heard this piercing sound. They started experiencing severe headaches, tinnitus, dizziness, and some of those symptoms or many of those symptoms persisted. So they became like career limiting. They were not able to work, the diplomats were pulled. And initially in the intelligence community, the idea was that these were sonic attacks. But then the National Academy of Science, Engineering, and Medicine released a report saying that they were more like high energy pulses, maybe microwave attacks. Some of our adversaries, have microwave weapons, so it could be that. The latest statement from the government is that there are no hostile forces. Maybe there's no evidence of that. But there was also an article in December 2020 in JAMA in which they actually looked at the brain scans of those suffering from Havana syndrome. And they saw that they had changes resembling a concussion, but there were no physical sequelae, no physical signs of trauma to the skull. And so it was called the mystery of the immaculate concussion. And there was actually a New York Times piece about this, right? Is this an act of war or is there a functional overlay? And if it's been seen in other embassies, does it have a functional overlay? But certainly in discussing with some of the people who work at Walter Reed, their general sense is that something happened. These people are having a response to it. We don't know what it was, but they're having a response to it. And, speaking of neurovalidation, as Dr. Jimenez so eloquently told us, basically, when people are not validated or when they're told there was nothing, maybe this is mass psychogenic illness, that can actually exacerbate or perpetuate symptoms. So that's an important thing to keep in mind. But it is very fascinating. All right. We also did consultations at the Armed Forces Retirement Home, which is a retirement home for the enlisted. So that's sort of, a nursing home kind of consultations. Just wanted to quickly mention, I do a lot of transplant. I won't spend a whole lot of time talking about it, but Walter Reed has a wonderful kidney transplant program and also kidney donors. So, people used to come in saying that they wanted to donate to someone, and often there was this sense of feeling connected or feeling like it was meaningful to donate to somebody within the extended military family, whether a military service member, whether a veteran or a military spouse. Boxer evals. So have people heard of this? I know it's very, very specific to working in the military health system. But basically, the idea is that these are evals that also the CL service used to be tasked to do on the inpatient service. So basically, in order to protect service members from retaliation from their command for whistleblowing, etc., historically, they created this layer of protection that when somebody is involuntarily committed to an inpatient psych unit who is an active duty service member, then an independent evaluator has to do an evaluation to make sure that they actually need to be there on an involuntary basis. I think I've touched upon this a little bit, but like I said, there's dual responsibility. As CL psychiatrists, we are used to taking care of the patient, but doing liaison work with teams. And when you are in the military, again, you have this dual agency. You are a consultant to the command. You're helping the commander make decisions about, whether somebody should deploy, whether somebody should be on temporary duty or a profile, etc. Also, there is something called the commander HIPAA exception. So when you're communicating with commands, there are certain situations like danger to self, danger to others, danger to the mission, etc., or for certain special personnel, certain specific things where you can share the diagnosis. And again, I think all providers try to be as respectful and as to the point about it, not sharing somebody's whole life story, but really things that are pertinent for the commander to know. All right, my deployment. So just wanted to give you an aerial view of Camp Arif Jan in Kuwait. I was there for 9 months. I lived in something called a CHU, which is a containerized housing unit, also informally called a pod. We were under General Order number 1, which means you couldn't drink alcohol during the whole deployment. Also, for the most part, we were on this military base. We only were allowed to leave when there were scheduled morale, welfare, recreation trips. No two deployments are the same. This is really important because whenever you sort of take care of a service member or a veteran, and I think, there were statistics, these are a little old, but from 2006, that about 66% of veterans actually get their care outside of the VA. So you might, be taking care of veterans even if you're not working in the VA setting. And so I think it's really important to remember that no two deployments for two people who deployed at the same time even are the same. And even for the same person, like I worked with people on deployment who would say things like, yeah, my previous deployment, I was single. So I just I could enjoy this deployment. Whereas now I have a 2-year-old. So, the deployment is much more emotionally challenging because I feel like I'm away from my child. These are the kind of CHUs in which we lived. These are some other photographs. Okay, so this was the name of our combat operational stress detachment. A detachment is a small unit that's supporting a larger unit, roughly. So we were supporting as the 98th Medical Detachment, we were supporting this 31st Combat Surgical Hospital, and Mind Menders was supposed to be the logo. I didn't come up with it, but actually it was a lot of fun to have this brand that we're the Mind Menders. This is from the Army Combat Operational Stress Control Doctrine, that the whole purpose of a unit like that is really to help enhance adaptive stress reactions, minimize maladaptive stress reactions, promote readiness, take care of people with behavioral disorders. And for the most part, what we did was outpatient work. People would come in, talk about, some of the relationship troubles that they were having. Now in the age of social media, it's particularly difficult. Sometimes when there are fault lines in relationships, they can really widen, from not being able to see somebody for 9 months. And social media can also complicate that. We also had a makeshift inpatient facility. And that was really sort of, for the most part, holding patients for medical evacuation, because that inpatient facility was for people who were suicidal or psychotic and really could not stay on the deployment. I will say, and then there was also outreach. So this is part of the liaison work, right? Because liaison is about building a relationship. And so this was liaison work with different units. Like when we were stationed there, and even when I forward deployed to Jordan, we went and met the leadership of different units and said, what are you seeing in your units? How can we help? What briefings to your soldiers might be helpful? So there was certainly that element. And these were some of the flyers that we had on the base. I just thought it might be interesting to invite people to come in, because otherwise they may not know, that there is a behavioral health support team there. This is another one. This is something called the Central Command Medical Waiver Request. So I just wanted to put that in there to say that basically for deployment, certainly there are some deployment limiting conditions, but for the most part, you have to demonstrate 90 days of stability. And this is clinically relevant because sometimes people have this idea that, oh, I can't be on an SSRI or an antidepressant for deployment. And that's not true. You cannot be unstable. So, certainly if you have a patient that says, I'm going to deploy, take me off my SSRI, that's not really appropriate because then you would actually destabilize them and create problems. However, there are some medications, benzos, stimulants, etc., that you need a special waiver for. And even when we were in theater, there were people who came in with ADHD symptoms and, maybe a stimulant would help their functionality. And so we had to send these requests. So clinical situations and deployment, I've mentioned some of the relationship issues. One thing that was very interesting that I think is relevant to CL is that in CL, we often do suicide risk assessments, whether they're on the floors, whether they are in an emergency room or acute setting. And it was interesting because here the stakes were really sending you back, not completing the deployment. Like if you were really suicidal, then basically the assessment would be that you can't stay in Kuwait because you need a higher level of care. You have to go back, or you can't stay in Jordan. And it's interesting because I think that on the one hand, there are guidelines about this, but on the other hand, I think there's also this pragmatic approach. What are the reasons for this person to complete the deployment? And what are for that person, is this person, do you think that they can complete the deployment, or do you think it is too unsafe for them to do that? And I think that there is a little bit of provider variability in being risk averse or being cautious that can come into play. So for instance, one example would be, I had somebody come to me that had this aborted suicide attempt. He was a private first class. I think that he had some conflicts in his unit, and he basically took like Tylenol, in his hand, but then he got this thought in his head, no, this is a permanent solution to a temporary problem. And he stopped it. But when he came to me, he was not suicidal, even though he did technically have this aborted suicide attempt. He said that, he wanted to complete the deployment and he had reasons to stay, and he did complete the deployment. And actually, it was very meaningful for him to have a deployment under his belt. And so you have to see, again, that layer of secondary gain, right? Some people may just not be happy on the deployment. There are stresses of the deployment, may have problems with their colleagues or their commander, and may want to leave. And so part of the assessment is really figuring out practically what the best course of action is. When I was in Jordan for 2 weeks, it was a very short period of time, but it was actually sort of like CL, because you would see people that you would see only once. Sometimes it was very therapeutic for them to sort of express what their experience of the deployment was like. I'd mentioned earlier that there's a lot of regulations. So one of the things that we did see on deployment was something that we don't see as much in what is called garrison in country, which is that people often, there were investigations for, inappropriate relationships, sexual harassment, etc. And there are many layers to this. Sometimes there were units there that didn't have as full or as active a mission. They had more time on hand, etc. And sometimes it was that they were activated reservists that were actually deploying with people that they don't work with on a day-to-day basis in country. So it was really sort of a new group of people, group dynamics, etc. This is Jordan. All right. So lessons that I learned from my deployment. So one of the very human lessons I learned was really about the value of social connection. Human beings are social animals. And of course, I knew that. But I think that when I deployed, it was with a group of people that, we worked every day together. We went to the DFAC, the dining facility together. We, worked out together. We did recreational stuff together. And so it really felt like a siblinghood, like brothers and sisters. And that actually made me reflect on some of my relationships back here in country, where I felt like, even my closest friends, sometimes we meet every 3 months for dinner, and that's great. But there's something about this kind of connection that's very special, very unique, that modern life doesn't always lend itself to. Another thing that I learned was, the Army was all about leadership. The residents that train in the military are often given leadership positions very early on in their careers. You do this basic officer leadership course, and they tell you leadership is motivation, leadership is influence. And one of the things that I learned during the deployment was really how important it was for a leader to create a sense of mission or a framework of meaning. So for us who were psychiatrists, it really felt like, oh, there are people coming to our clinic and we're taking care of them. There was a sense of doing something meaningful. But there were some units which there was no active combat there. And so they didn't have as clear a sense of meaning. And so, sometimes they would get demoralized or disgruntled or, oh, why am I here for 9 months when my family's back there? And so the function of the leader really is to create that framework of meaning. Also, I've put there boundaries. So when I was on deployment, it really felt like being the village doctor, because you would see your patients, near the bathrooms. You would see your patients even in some of the morale, welfare, recreation things like the Halloween event. I was an actor in a haunted house, and some of my patients told me, "Oh, we saw you, yeah," or "We heard you at karaoke." So that's something that you don't usually see, and probably could be the stuff of a psychodynamic paper. Just wanted to reinforce this with a little bit of data. So there was actually in this mental health advisory team in Operation Enduring Freedom, they had this report in which they have this little like Punnett square about officer leadership and NCO leadership. So in a unit, you have an officer, usually like the company commander, who's a captain, and you have the non-commissioned officer leadership, who's generally a senior sergeant, staff sergeant, etc., or sergeant first class. And it's interesting because they actually found a relationship between soldiers screening positive for psychological symptoms and ineffective leadership as perceived by those service members. And of course, if both the leaders were ineffective or perceived to be that way, there were very high psychological symptoms. So I think that when you go out, as all the fellows, as attendings, I think that you're the leaders of the future, and this is important to know that. Certainly you have an impact on the psychological health of your team. All right, and this is one of my last slides, but I think I've talked about the when, I've talked about the what, but I haven't talked about the why. How did this come about in my life? So as an immigrant, I came to the United States on something called a J1 visa that many of you may be familiar with. And this basically necessitated that I either go back to my home country after 7 years or do a waiver in an underserved area. And I was looking for opportunities, nothing very exciting. And so when I was at Northwell, actually during my geriatric fellowship, a military recruiter came and talked to us. And initially I thought maybe it wasn't applicable to me given the visa situation, but he mentioned this program called MAVNI, by which you have a pathway to citizenship in exchange for military service. So even though that's true, and there was sort of that layer of secondary gain, if you will, but I think it doesn't capture the primary gain, which is that I felt a great sense of excitement when I heard about the possibility of deployment. I felt a great sense of almost like a call to adventure. It seemed very exciting as a life experience. And I think I wasn't wrong. I think that even after having gotten out of the military, I look back on it as a very memorable adventure. Concluding points, lessons, I'll say the second thing first, all your skills. So what I realized in the deployed setting is that in an austere environment or in an environment where you don't have all the resources that you have here, it can really be helpful to have a broad armamentarium of skills. So if you're ever in a situation like that, certainly broadening that, train in CBT, train in trauma-focused therapy. And I heard a lot about trauma-focused therapy in the military. Happy to talk about it. But I actually wish that I had, learned more about that, which could have been helpful during the deployment. The future is unknowable, so micromanaging it can sometimes be futile. I think that 10 years ago, if you had told me that I was going to be an officer in the army and I was going to, carry a gun to Kuwait, I would have thought you were speaking about a different person. And yet, this is what happened in my life. And this was one of the most memorable experiences. So just something I wanted to leave you with, if you have some uncertainty about the next steps in your career, etc., just remember that, you never know. Opportunities come up. Just have sort of an open mind and an open heart. Also, if you found some of these things interesting or fascinating, I definitely think that there's a lot of need clinically and a lot of gaps in the literature as well. So you don't have to be in uniform in order to work in the military health system. You can work as a government services civilian. You can also work as a contractor. Certainly GS civilians, have a whole package of benefits, etc., that can be appealing to people. So just something to keep in mind. And again, want to reiterate that the military, the army, not a monolith. And also the military is bigger than the army, and each service has its own culture. So I've given you all this about the army, but the Navy is its own whole culture that's different. And when you work with a veteran, when you work with a service member, don't assume that they have deployed. Don't assume that they have combat trauma. Don't make they could have had a desk job. So don't assume, ask about it. And these are all the wonderful people, all SLP, certainly. Thank you so much to Qureshi, Dr. Thickerman, to Angelova, and all the wonderful people. And I just wanted to thank fellow service members, everybody that I've served with, and all the people at different institutions I've worked at and trained at, Memorial Sloan Kettering Cancer Center, all the residents, fellows, med students that I've always learned so much from, the patients that I continue to always learn from, Dr. Angelova, Bino, Ernst, Yadav, Lavochkina, and my military, Colonel Waits, Dr. Wayne, Dr. Ford, Dr. Amin, special acknowledgements to them. But thank you all.
Thank you so much for that amazing talk. I actually had a quick question, if people don't mind staying for 1 second. I know you mentioned you do transplant work as well, and I was kind of struck by the similarity between the elective amputation, clearance consultations, the overlap between that and kind of some of the transplant psychiatric clearance evaluations. And I was just wondering, from your perspective, what were some of the similarities and differences doing those? How did you feel doing those evaluations? And did you feel like there was any overlap?
Yeah, that is a wonderful question. And I think that I will say that even in the transplant world, like we often say that transplant psychiatry, if you spend a whole weekend, you can read most of the literature that's out there about it, maybe 1 week, maybe not a weekend. But with delayed amputation or elective amputation evals, it's very hard to find very much literature, but I think that we always sort of build upon reference points that we already have. And I absolutely agree that there are lots of parallels. So for instance, certainly screening for psychiatric conditions. So if you're looking at elective amputations, some of the absolute contraindications would be some of the absolute contraindications for transplant as well. So for instance, suicidality, recent suicide attempt, psychosis, mania, active substance use disorder, these would certainly overlap. There may be some things that don't feature quite as commonly in transplant, like factitious disorder would be something you'd really, have to have your mind open for and screen for. Certainly that apotemnophilia, or wanting to be part of like this wannabe amputee group, that would be something. But the other thing you would look for, which I think is common, is sort of the decision-making process. Is this an impulsive decision? Has this person thought about it? Do they have support? What is their distress tolerance? So one of the things that's not an absolute contraindication, but sometimes can be either a relative contraindication or just something that needs support, something that you need to keep an eye on, is in transplant, the ability to work with a team, right? Because in transplant, you are surrendering a little bit of control over your body. If somebody calls you and says, you need to come in, your prograph level is really high, you can't generally be the kind of person who says, oh no, I have a trip planned, I have to head out, bye. That wouldn't really help the graft, right? So in the same way for amputation, you do, even though this is not an absolute contraindication, I think that you have to identify the strengths of and the vulnerabilities and identify if this person's personality or maladaptive coping or distress tolerance is going to interfere with their ability to participate in the extensive rehab, to take care of the prosthesis and things like that. So I think that there's that commonality. And I would say the other commonality is the importance and value of psychiatry in improving outcomes. I think that this is where we go back to the roots of the therapeutic alliance, right? I think that identifying these problems is one thing, but as a psychiatrist, really connecting to a patient, understanding who the patient is more than what the disease is, can be really helpful in long-term outcomes.
Great, thank you. Other questions?
I guess in that same vein, I'm curious, these patients who want to elect for an inpatient, that typically solve their main issues, or is it like 50-50 or something?
That is such a great question. So I think that as far as functionality is concerned, so I want to acknowledge that, I shared a little bit about the data, and I'll share my own experience as well. So the data seems to bear out that there's functional improvement. Also, one has to remember that I had this slide about the complex regional pain syndrome, but that is one subset. That's one cohort. Like, not all the patients that we evaluate have a chronic pain syndrome. In fact, really, in my experience, the biggest thing that people are looking for is improvement in functionality, because as you can imagine, a lot of military service members are very invested in, physical fitness, running, etc. So what they're really looking for is not so much I'm in pain all the time, but really more that I've had these limb salvage surgeries, but I'm not really able to walk and run. And I see people with prosthesis who are, participating in Paralympics and doing so well. So that does improve. I think pain is trickier because even though the studies seem to show, and the study, bear in mind, was not RCTs because it's hard to randomize amputation, right? So the study seemed to show sort of a mixed picture. On the one hand, they said most of the people who for CRPS had got an amputation said that I feel my quality of life is improved. But on the other hand, did they have a recurrence of pain? I mean, there were fairly high rates of that. So I think that it's complex, but also, as I mentioned earlier, one of the things that I saw in that study was that whenever there was a multidisciplinary approach, when the person was truly treatment refractory to all interventions, including psychological, not just like nerve blocks and ketamine and all that, but also had psychological screening, care, etc., was still treatment refractory and had good psychological support pre-op, they actually did well in terms of functionality, if not pain. But more data is certainly needed.
There's an interesting documentary about Boston Marathon where they follow a husband and wife, both had limb injuries. The husband, they just needed to amputate right away. The wife, however, they were able to do it salvage. But it's interesting because the husband ends up being much more functional, running, runs a marathon, and the wife ends up choosing electric amputation and can't even walk.
Oh, wow. That's so interesting. What is the name of this documentary? I would love to see it. I mean, this is exactly on theme with, and like I said, that metal study seemed to show that, though it was a retrospective cohort study. But to me personally, like I said, because I had certain expectations about what amputation looked like, it was just something very mind-blowing or paradigm shifting. Other questions? Oh.
Thank you, everyone.
Thank you.